Since it is time to start the 2024 Fukushima Medical University International Symposium on the Fukushima Health Management Survey, I would like to declare the opening of this symposium. Now, I would like to ask the Nolet Kenneth to act as MC. And Nolet, Dr. Nolet, please.
Thank you, Ms. Tsuchiya. Welcome to the 2024 International Symposium on the Fukushima Health Management Survey. Today's hybrid symposium includes online participants, a live audience here in Tokyo, and another at Fukushima Medical University's School of Health Sciences. Hello, I'm Kenneth Nolet, an American by birth and, since 2008, a resident of Fukushima by choice. Once again, we are fortunate to have reporters, journalists, and videographers on site and online today. Honest, independent media are essential in today's world, and we are grateful to have earned your time, your attention, and your service to readers, listeners, and viewers around the world. Let's begin with words from FMU President Takenoshita Seiji, whose long service includes prior appointments as our hospital director and vice president, during which he guided much of our response to the 2011 earthquake, tsunami, and nuclear crisis. President Takenoshita.
I am Takenoshita from the Fukushima Medical University. First of all, I'd like to express my deepest condolences to the families who have lost their lives, property, and their livelihood in the 2024 Noto Peninsula earthquake. And we continuously send in the medical team, and we are providing the support activities based on our experience from 3/11. We are hoping that the earliest possible time recovery. So it is an honor to welcome you to our 2024 International Symposium on the Fukushima Health Management Survey. This year, we have decided to hold the symposium in Tokyo for the first time as a main venue, with the satellite venue in Fukushima, in the strong hope that not only people of Fukushima Prefecture, but also people throughout Japan and around the world to know about the findings achievement of Fukushima Health Management Survey. We thank you very much. And also, in the TEPCO Fukushima Daiichi nuclear power plant, it will be 13 years very shortly, and we'd like to express our sincere gratitude for your tremendous kindness and support during this period. After the disaster, FMU declared our commitment to support the revitalization of Fukushima from health and medical perspective immediately after 3/11 disaster. And since then, in addition to the traditional mission to education, research, and medical care, we have pursued our historical mission of protecting the health of the people in Fukushima. The last 13 years have a series of new challenges for the university to achieve these missions at the higher levels. And we have finally reached the stage where we can turn our sincere and relentless efforts from the desperate environment into hopes and dreams and pass them on to the future generations. And this symposium is organized from the viewpoint of turning the experiences and knowledge we have gained from revitalization processes from the unprecedented complex disaster into the systematic and the universal shared knowledge of the humankind. We hope that all participants in this symposium from Japan and abroad will be fully engaged in our discussions and offer opinions from their own respective perspectives. May this symposium be fruitful for all of you who participate. Takenoshita Seiichi, I'm a president and also the dean of the FMU. It will be a long-term symposium, but please stay with us till the end. Thank you very much.
Thank you, President Takenoshita. Incidental to President Takenoshita's always busy schedule, he's actually spent the last couple of afternoons attending ceremonial last lectures from professors of retirement age here at FMU. This is a poignant reminder of our need to transmit the experiences of 311 to subsequent generations. As evidence of our efforts in this direction, among today's participants are some of the most longest serving professors at FMU, along with some of the youngest professors at FMU. You'll be hearing from them later. Now, let's hear a recorded message from Governor Uchibori Masao.
Good morning, everyone. I am Masao Uchibori, the governor of Fukushima Prefecture. In 2010, and it is an honor to have this opportunity to extend my greeting to all of you at the opening of a 2024 Fukushima Medical University International Symposium on the Fukushima Health Management Surveys. And thank you very much for joining us today from Japan abroad. And let me also express my deep respect for the past research activities and thank you once again for your ongoing understanding and support for the revitalization of Fukushima. And in light of the accident at TEPCO's Fukushima Daiichi nuclear power plant, the Fukushima Prefecture government has conducted Fukushima Health Management Survey with the cooperation of Fukushima Medical University in order to maintain and promote the health of all residents of the prefecture for the future. As 13 years will have soon passed since the nuclear power plant accident, there is a concern that the memories of the accident will fade and the misunderstanding caused by rumors will become fixed. In order for people to properly realize the Fukushima now, it is necessary to continue to disseminate easy to understand information based on the scientific evidence, such as the result of the survey, and further expand the correct understanding of radiation. Today's symposium will be the first to be held in Tokyo metropolitan area. By reviewing the Fukushima Health Management Survey so far, sharing our experiences and the scientific findings obtained through the survey, and deepening the discussion, I expect that the latest information will be widely disseminated from here in Tokyo to the rest of Japan and the world. The Fukushima Prefecture government will continue to work closely with Fukushima Medical University, including Fukushima Health Management Survey, to ensure the safety and security of the people in Fukushima. I would like to ask for your continued support and cooperation with your extensive experience and knowledge to our effort. And in conclusion, let me express my best wishes for the fruitful symposium and for the continued good health and success of all those attending today, including those who are participating online.
Thank you, Governor Uchibori. For those of you not familiar with Fukushima City, the governor's residence is just 1 block away from the prefectural head offices. Before 311, a governor could do his job within a small radius. But since 311, our governor has become kind of an international ambassador for Fukushima in particular and Japan in general, as we try and help the world understand that it's safe and delicious to enjoy our seafood and the products from Fukushima's rich agricultural land. So we are grateful for his efforts in all of these regards. So we're also grateful that he took the time to give us this message, even though he couldn't physically be here at the venue. Now it's a pleasure to introduce FMU General Vice President Oto Hitoshi, whose biography appears on pages 8 and 9. As a professor emeritus, Dr. Oto helps direct the Fukushima Health Management Survey, while continuing to be active in the academic discipline of transfusion medicine, especially in regard to maternal, fetal, and neonatal health. Professor Oto.
Yes, thank you, Norit. これから安村誠二先生の紹介を申し上げます。
Thank you for your kind introduction. Let me introduce Dr. Yasumura Seiji. He took office as president of professor of FMU as a radiation executive director, Radiation Medical Science Center for Fukushima Health Management Survey. We started conducting FHMU, and he launched a center and led in the effort to stipulate the protocol. He has been consistently made an effort to protect the health of the resident. After Dr. Kamiya, he was appointed as the head of the center. He has making a steady effort to protect the resident health. Thank you for your kind introduction and good morning. My name is Yasumura. I am the head of Radiation Medical Center for FHMS. First, let me extend my gratitude for being able to host the 2024 FMU International Symposium for the Fukushima Health Management Survey. As the governor noted, it's important opportunity for us to send the messages to the world about Fukushima. Also, I'd like to express my gratitude for Dr. May Abdel Wahab, who have kindly accepted our invitation to the keynote lecture. Although she is not able to join us face-to-face here, but she will deliver the keynote address online and as well as the participation to the discussion. Let me give you the overview of the Fukushima Health Management Survey. During the session 1, doctors in charge of each component of FHMS will give you presentations. In session 2, we will also cover various activities conducted in the prefecture so that you would understand more about their achievement. It is a full-day session. I hope you would stay until the end. Thank you. Let's move on to my presentation. I will cover these 4 topics. The first topic is the nuclear disaster after the Great East Japan earthquake and its impact on people. 1,600 people lost their lives in Fukushima due to earthquake and tsunami, which is less than the death toll in Miyagi or Iwate. However, it is still high. Also, we have to take note of the number of disaster-related deaths. 2,337 died of that because of disaster-related death cause. But I'd like to emphasize here one thing. What is called tribal disaster was the situation. However, none of the residents had deceased because of the radiation. After the earthquake, radioactive substances were released from the TEPCO Fukushima Daiichi nuclear power plant, and Okumamachi, Futabamachi, and other municipalities recorded a very high air dose rate, about 100 microsievert per hour. That high air dose rate declined over time, but right after the disaster, the rate was quite high. Please bear in mind it was 100. And the blue line shows the Fukushima city's air dose rate, which is distanced from 100 kilometers from the plant. And this is 2.74. So it's close to 3 microsievert, and it is a low figure compared to the ones at the rate at the municipalities closer to the nuclear power plant. It is still relatively high, and due to the climate on the day in Fukushima, we have detected somewhat considerable air dose rate, unlike Iwaki and Aizu Wakamatsu City, and they also declined over time. Air dose mapped after 1 month after the disaster. The wind flew northwest and then south. And Hamadori area are close to the coast, and Nakadori in the mid, and Aizu further west. And a considerable amount, a certain amount of dose was recorded. And according to the dose distribution, the government designated evacuation area and evacuation area and other evacuation classification areas. About 2,000 people died because of the disaster. But that figure includes deaths because of indirect cause of the disaster. Compared to Iwate and Miyagi, disaster-related fatality is especially high. And also, if you look at the age group distribution, ages 20 and younger, and 21 to 65, and ages 66 and older, you will notice that elderly population stand out from the left. So there is a very high percentage of the deaths among older people, and indirect non-disaster-related fatalities as well. That's why we started the FHMS, Fukushima Health Management Survey. The purpose is to relieve anxiety after nuclear accident and to protect and promote the long-term health of Fukushima residents. And ultimately, the goal is to protect and promote the long-term health of Fukushima residents. Of course, direct impact of the radioactive substances are one of the purposes, but the goal of the FHMS ultimately is to protect and promote the long-term health of the residents. This is how FHMS is set up. To the left, you will see basic survey. Of all the residents, 2 million residents were eligible for the basic study to estimate the overall dose rate. And on the right, and you would see TUE, thyroid examination, and a comprehensive health check on CHC, and a mental health and lifestyle survey, and the pregnancy and birth survey, 4 components. The purpose is to ascertain health conditions from epidemiological viewpoint. What is on the left is the cause, and on the right, there are outcomes. In terms of the purpose, one of our ultimate goal is to make the data set and analyze it to ensure good follow-up. And in order to deliver good follow-up, you need evidence and good data. That's how the entire FHMS is set up. Here is the detail. And in session 1, each component is going to be explained by each doctor. So let me go over just the overview of it. So let me talk about first the basic survey. Over 2 billion people were eligible, and 460,000 returned the questionnaire, and then my message here is that external exposure of the initial 4 months period is less than 5 millisievert in 99.8% of the respondent. As a result, that we consider that the radiation level is not at a level where health effect can be confirmed with statistical significance. And then we conducted the TUE, and the first round was, in the first round, 730,000 were eligible for the preliminary. And then a full-scale survey was conducted. And for this survey, there are advantages and disadvantages. It's important to understand the advantages and the disadvantages before making a decision to take the examination. So we consider it is important to create an explanatory materials and sometimes conduct one-on-one explanatory sessions so that a resident can make an informed decision. Last year, we also created an explanatory animation video for young generation. So far, we have concluded the 5th round. Malignant or suspicious for malignancy cases. To date, we have detected 328 cases. In a preliminary baseline survey, we detected 116, and then 71 and 31 until 5, and it's on a constant decline. the eligible residents were 367,000, and now it has declined slightly less than 300,000. This graph shows that different behavior for evacuation resulted in different exposure dose. And according to ANSCA, the average observed dose to the thyroid in the first year to infant was 2 milligray to 30 milligray. The similar estimation was made to Chernobyl accident evacuees, and then the mean thyroid dose was 330 milligray for Ukraine. So according to that unscared data, the Fukushima's average observed dose is very significantly lower than the Ukraine dose. And based on the result, we have conducted analysis using multiple methodologies. The current method is nested case control study, where the case group is compared to control group using multiple variant, and we made multiple modifications, and the result is on the right. The horizontal axis, the dose, and vertical axis, the odds ratio or detection ratio, and our conclusion is that there is no significant dose effect ratio. It was already reported to Prefecture Oversight Committee, and the committee's view is that there is no evidence of an association between thyroid cancer and radiation exposure. Our view also agrees to that. We also offer support to residents who took the primary examination and the confirmatory examination. Next, comprehensive health check, or CHC. All the residents in the 13 municipalities were eligible, amounting to 210,000 residents. According to age groups, check items are different, but the purpose is to gauge the health effect of the evacuation. The result, as you can see in the mid, risk factor seems to have increased. However, on an overall level, no findings indicated radiation effects were found in the result of the CHC. In the CHC, based on the result, we have provided leaflets and conducted a seminar in support of the residents. Next, mental health and lifestyle survey, or MHLS, whose eligibility is completely the same with the CHC. We send a questionnaire to the eligible residents to assess their mental health and lifestyle. This shows the percentage of the residents who require mental support. It's on the constant decline. However, recently it seems to come up, and which we are really concerned with. And 3.0% shows the average all Japan. So among evacuees, the percentage is 6.1%. 6.1% require mental support. The next question is children. Indicator used here is STQ, score of 16 or higher. Means that the child require special support. The result in all age category showed a higher percentage, but fortunately, the mental status of children has improved to almost to the same level of all Japan level. However, there are residents with mental health issue and lifestyle issue. They need special care, so we offer the care. And also we approach groups to reduce risks. The last component is PBS, or Pregnancy and Birth Survey. In 2011, right after the disaster, there were a lot of disastrous media report like that you cannot deliver. For example, you should not get pregnant in Fukushima because you cannot deliver a baby. That daunting headlines made 17,000 pregnant women very unhappy and anxious. We decided to provide necessary care for them and started sending questionnaire to them as part of PBS. We also conducted the follow-up survey with midwives and public health nurses and certified public psychologists. Later, we will show you and explain the details. We looked at the preterm delivery and the low birth weight infant and the congenital anomalies percentages. And there are some misunderstandings. And every year, we report the result of these indicators. And in any one of the indicators, Fukushima's percentage is not higher than the national average in 10 years. So there hasn't been any major issue. That's why we decided to terminate PBS. A lot of pregnant women expressed anxiety and depression when we conducted a telephone-based survey, but such people's percentage is on the decline. This is a summary that I put on the report. We have to be interactive and conduct public relations activities in an engaging way. And also it's important to share the information that is really needed by the residents. Last component, as Governor Uchibori noted, one thing that we still regret is that when we conduct a survey nationwide and ask them if they think that there is a heritable radiation health effect, particularly to Fukushima, about 40% say yes, there is a high heritable radiation health effect risk. And we consider this is quite problematic. As I mentioned earlier, the congenital anomaly rate is not high, no higher than the national average. Lastly, the disaster's effect is still unfolding. The important point I'd like to emphasize is the core part of the problem is whether the dignity of their place of living is maintained. We want to protect Fukushima so that a resident can live an ordinary life with a peace of mind. This is the end of my presentation. Thank you so much for your attention. Thank you, Dr. Yasumura. It's been 13 years since we started the FHMS. From Fukushima and Fukushima resident to the world and maybe to the next generation, if there is any message you want to send, share it from now. Strong message. This is the 6th symposium. What I want to tell is what's really happening, the realities. What's happening in Fukushima now that needed to be told without distortion. And then there wouldn't be any misunderstanding or prejudice. From the world or maybe the resident outside of the Fukushima, what's happening in Fukushima is not their business. But if your town is located close to the nuclear power plant and if the plant causes an accident, you would experience the same. So please remember Fukushima and do not forget.
What we have learned from the people of Fukushima. It's a pleasure to introduce FMU professors Shimura Hiroki and Ohira Tetsuya, whose biographies appear on pages 14 through 17. Both were appointed as professors in 2013, greatly enhancing our post-disaster expertise. Gentlemen.
So I'm the chair for session 1. My name is Shimura. My name is Ohira. Thank you very much for having us. So without further ado, we want to start with the first presentation. Ms. Dr. Tetsuo Ishikawa from FMU. The title of the presentation is Experience in Dose Estimation Involving Around 2 million People for the Basic Survey. If you go to page 18, you can find his biography. Dr. Ishikawa, the floor is yours. This is Ishikawa from my side. I want to walk you through about the basic survey. So let me begin. So this is the circumstances in early post-accident period in Fukushima Prefecture and also overall East Japan, that the environment radiation level arose sharply. As you see on the graph on the bottom left, you can find the ambient radiation dose in Fukushima City from March 11th, the day the earthquake occurred, to the end of the month. Before the accident, the level was about 0.05 as a value, but after the accident, it went up to 24. The figures in the graph are in microsievert per hour. About 6 months after the accident, as you see in these photos, municipalities distributed personal dosimeters to the residents and to measure or estimate the dose. And after that, as you see in this picture, the monitoring post to indicate the air dose, ambient dose rate. However, right after the accident, this kind of measuring devices of the dose or devices were not available widely. So residents to understand their own dose level was very difficult. So therefore, residents were asked to record and send back information on their behavior in the early post-accident period. Individual external doses were estimated based on their behaviors and notified to the respondents by post. This is the basic survey. The purpose of this survey was to ascertain the overall level of exposure of the residents in Fukushima Prefecture and to provide basic data for subsequent health management. The eligible people were the registered residents in Fukushima Prefecture between March 11th and July 1st, 2011. We covered about 2 million people. So distribution of a questionnaire was started to those people at the end of June 2011. And you can see that image of the questionnaire on the slide. So basically, the people who lived in Fukushima Prefecture at the time who were registered in another prefecture, and those who commute to work or school in the prefecture from outside the prefecture were also eligible for the program upon request. This is a sample of the main section of the questionnaire filled by the residents. From March 11th to March 25th, the residents were asked to populate this form, including their whereabouts on an hourly basis, and if they stayed indoors or outdoor. After March 26th until July 11th, it was a simplified form. They filled in the place of residence and average time they spent outdoor and also where they went to school or work. So this form was used until July 11th, so that those estimation period was also for 4 months. This survey covered all age groups. Minors were required to submit the form with the signature of their parents or guardian. So this is an image of how the dose was estimated. As I showed you before in the questionnaire, they populated whereabout, and it is converted into latitude and also longitude. And it was overlaid with ambient dose rate map in the computer in order to estimate the individual's exposure dose. As it was in the questionnaire earlier, where they spend time in indoor and outdoor. That is also included if they were in indoors. The seating effect of the building was also factored into the estimate. This calculation program was developed by National Institute of Radiological Science at that time. So this is the flow of the basic survey. The first flow is to notify and provide information to the residents, and also the survey to grasp the overall trends. So there are two main flows. So we distributed the questionnaire, and after those are populated, it was sent back by post. However, we are not just waiting for the mail to come in. We tried to outreach. We went out to the place where people gather so that we were able to collect the questionnaires or the response. And this is how we supported our residents to fill in the questionnaires. And the collected questionnaire was in handwriting. We needed to digitize so that we were able to put into the program. So if there is any information missing in the questionnaire, for example, they just filled in. They were at the relative's house about the whereabouts, and we were not able to convert that information into latitude and longitude. So we needed to contact them in order to get the exact address where they were staying. So we contacted over 60 million people in order to populate more information into the questionnaire. And after doing this, we tried to digitize the activity record. Right after we sent the questionnaires, we received a lot of responses. At the peak, we received about 8,000 responses a day. So for every response, every respondent, we notified the result of dose estimate and so forth. And also, we gathered information by age and also area, and we submit that information to the oversight committee, and also we have publicized our paper. This was in the earlier slide. This is how we supported the residents how to write and fill in the questionnaire. We went to the place where residents gather If they did not submit the response of the questionnaire, then we help them to fill in the questionnaire. In the past, we visited like a temporary housing and also TUE venue and also a health check venue in each cities and villages and also at the city hall building. This is since this is the support we offered, but overall response rate was 27.7% in the prefecture. However, there was a difference in different areas. We have a map showing the different response rate in each area, where nuclear power plant was, and also the areas around that was, the response rate was around 40%. And there were 8 municipalities with over 50% response rate. But overall, the response rate was not really high. That's why we have done the research over representativeness. And due to the interest of time, I will not go into the details. However, because of the study, we was able to identify all the responses we collected did not have any bias, and it represented the entire prefecture. And this is that some part of the form we notified to each individual. So after we get the response, we notified the dose estimate to each individual. The form, the time period that the form was for the activity record was for the 4-month time, but some people did not remember all the activities. However, there are responses which covered less than 4 months. In order to notify the dose estimate, we notified the time period used to estimate their dose level and also that dose estimate result. So far, we have notified the dose estimate result to about 555,000 people. So the people who filled in 4 months activity records, and this is a result of their dose estimate at the prefecture level. About 467,000 people responded to the questionnaire, and we have gathered the data. And as you see here, the average is about 0.8, and the maximum was 25 mil sieverts, and the majority of the people were below 3 mil sieverts. And based on the place they lived at the time of the accident, we have done the categorization, and we calculated the average dose, which is shown in this map. So area where the nuclear power plant exists, but many of the people, the dose result was less than 3 mil sievert. In the oversight committee, we had 4 months. Based on the 4 months worth of dose estimate. However, it is unlikely that the radiation dose impacted the residents' health conditions. That was the result of the evaluation. We gathered activity record from the residents, and I want to show you some examples. From the power plant within the 20 kilometers radius, right after the next day after the earthquake, the evacuation order was issued, and about 1 month later, in the areas colored with yellow, there was concern that the cumulative dose level could reach 20 mil sievert. So it was designated as planned evacuation areas. For example, Idate village and also part of Namie town too. In those areas, from the day it was designated, and they needed to evacuate within a month. Of course, exact date people evacuated were different, person by person. That was the assumption. WHO and also UNSCARE, those international institutions have done the dose the estimate for the residents in Fukushima Prefecture. You can find that the conditions on the right at WHO, and you have seen that the Namie town and also Idate village, they defined those areas as most impacted or affected by the accident. The people in those areas, WHO as of 2012 report, assuming that they lived in the planned evacuation area for 4 months and staying 8 hours outdoor, which is a very safe the assumption. And their evaluation result was 10 to 50 mil surveyed. And the 2013 UNSCARE report was issued, and after that there was UNSCARE 2020 and 2021 report using the actual evacuation patterns which were gathered by basic survey. The actual result was 1/10 of those international institutions report. So from the WHO report, from this data you can find how important it is to do their estimation based on their activities. So as I said, that the behavior or activity report was used in order to estimate the dose. And at the same time, this is used to estimate the internal exposure too. And apart from FHMS, after the accident, the waterborne and also that the airborne radio iodine concentration evaluation was done too. So using this and also activity report, analyzing those, like the internal dose in the thyroid gland and also the inhalation dose were estimated. And also that how much was taken in with the water. And so the external dose estimation from the basic survey was converted into external thyroid doses, and the internal thyroid doses were added together and used for case control studies on thyroid cancer. So this is a summary of what I reported. So due to the time, I will not go into the details. Would you please read this summary? I appreciate if you can read this summary. That's all for my part. Thank you very much. Dr. Ishikawa, thank you very much. If you have any questions, please use the question form. So
the topic is the current status of the thyroid ultrasound examination and scientific findings. Dr. Furuya, please. Please take a look at the program for his background information. My name is Furuya from Fukushima Medical University. I'd like to talk about the current status of the thyroid ultrasound examination and scientific findings. So this is the agenda for my presentation. So in the finding of the thyroid ultrasound examination is a thyroid cancer and also the relationship with the radiation exposure. And next, that as a possible related factor is what I'd like to present to you. Lastly, the current initiative for the TUE and the future initiative for TUE. And in the beginning, regarding the thyroid gland, I'd like to briefly talk about this. Thyroid gland is at the neck area. It is under the neck cartilage, and this is expansion. And thyroid and the follicular cell and the follicular lumen are the components, and the hormone T4 and T3, thyroid hormone, are generated by this, and the generated hormone is disseminated into the blood. On the other hand, that for instance, there are sometimes the cyst and the nodule, and the cyst and the nodule can be observed by the ultrasound examination. And in the Fukushima Health Management Survey, ultrasound testing is done so that we can check the presence of cyst and nodule. Because there is a possibility of the hidden cyst and nodule. And once that is found, then, and depending on size of that, the grade B or grade A are determined. 20.1 milli or larger for cyst, and also 5.1 milli or larger of the nodule, and then the secondary testing or examination will be done. The confirmatory examination is done with the blood test and the urine test. And according to the diagnostic standard, if that the malicious is suspicious, then the cystology is conducted. And as a result of that, if the malignance or possible malignance is found, and that will be moved to that the treatment covered by the insurance. This shows you the outline of the TUE practice so far, and right after the disaster, in the residents of Fukushima, the 18 years old at the time of disaster are the people covered, and this is the target. And as a preliminary baseline survey, the primary one is started from October 2011. Then, and for the purpose of a comparison, the full-scale survey are conducted from the second to the fifth round, until above 20 every 2 years, and above 25 years old, every 5 years, the examination is conducted. And so far, the fifth round has been completed. And up to the fifth round, this shows you the result of the examination. In the preliminary baseline survey, and the 367,000 people were covered, and the participation rate was 81.7%. And in the preliminary examination, 0.8% were moved to the confirmatory testing, and 92.2% participated this testing, and 116 people were diagnosed as a malignant or the suspicious of malignance. And since 2017, we started occasional examination, which covers 25 years old and higher. And from the result, let me talk about the findings we have gained. The first thing is the relationship with the thyroid cancer and also the radiation exposure doses. As already mentioned, let me talk about more detail. For the internal exposure doses, is the estimation we have from the water, and also the internal exposure doses. Then 1.1 is used to calculate the number of the up to fourth round, and also the testing from 25 years old, the people who were born in from the 2012 and the 18 who have the question about the malignancy. And in 2012 to 2018, out of the cases registered in the basic survey, if there are behavior records, and they are the eligible population, and also as a control, the sex and birth, and the malignancy or suspicion of malignancy through participation, And also, including the participation, the primary examination and records are used, and so that we were randomly selected at the ratio of 1 to 3 the cases to control. And this shows you the characteristic of the people. And the cases were registered as 153, and the control was 459. And the age at the time of disaster was on average 12.9. And also, this is the 2.3 to 2.1 as a medium of the equivalent. And this is the shown result, thyroid equivalent doses. The blue bar is odds ratio 1. And in that the eligible people, 3 millisievert or lower, or 3 to 12, or over 10 millisievert. And in each of the group, we have calculated that odds ratio. And in all of the group, odds ratio was about 1. There was no statistically meaningful change. And from this result, therefore, malignant or suspicious malignant detection and detection ratio and the exposure doses, there was no significant relationship. Then, and let me talk about the thyroid cancer and also the possible factor for the thyroid cancer. And this has been shown to you already. And this is outline of the TUE. And the yellow part is the participation rate of the primary exam. And also that the lower one is the participation rate of the confirmatory exam. 92.9% was the initial participation rate. But the primary exam and the confirmatory exam, and there was an inclining or reducing trend as we repeated the exams. And it's been pointed out there are regional differences of the participation rate. And you can see that map of Fukushima, evacuation area is yellow, and Hamadori is blue, green is Nakadori, Aizu is orange. And the participation rate of the confirmatory exam is shown on the upper chart, and it used to be 80 to 90%, but there were some regional differences, so 89 to 92%. So 3 to 4% variances were found. And also that see, this is the confirmatory examination at the lower chart. And for this participation rate is lower, 78% to 70%. So 8 to 6% differences of the participation rate was observed. And next, and in the confirmatory examination, when it was diagnosed as B, and this is a cytology participation rate, and the coloring is the same as the one before. And the upper right is the execution rate of the cytology for the primary survey, 47% in yellow, and we had much differences among the region for the preliminary baseline survey, and 5 to 8% for the confirmatory exam. And there are some differences by region. So these factors can impact the detection of the thyroid cancer. And next, I'm showing you again the outline of the exam, and the ratio or the detection rate of the B diagnosis. And in the 0.8% in the preliminary baseline survey, But in the full-scale survey, 0.8 to 0.7, not much difference. Starting from 2017, for 25 years old, B rate is 5.5%, as diagnosed as B. And this shows you the probability of getting the grade B, and also malignancy or suspicious malignancy are shown on the right by region, and age 0 to 24, cutting every 4 years. And B rate of B grade B, and yellow and the green, the third up to third. As you can see, as you get older, B ratio will increase, and that was consistent throughout the exam timing. The same tendency was found for the malignancy or suspicious of malignancy, and up to the third round, as you get older, the suspicious for malignancy goes up. The possibility or the probability goes up. And this shows you the overall result, the O. And for the B scoring, not much difference is what I found. On the other hand, malignancy or suspicious for malignancy, the first round was highest, but afterwards there's a declining trend as the number of rounds goes up. Then, the gender and B diagnosis or suspicious the malignancy or suspicious of malignancy, and the people up to the preliminary to third, but up to 2,005 people, and women was 66% to 67%. And for the malignancy or suspicious of malignancy, and it says 110 and 30 is 3 people. Among them, 66 to 58% were female. And this is the relationship of the thyroid cancer and obesity. And obesity is often pointed out as an association with the cancers, and the BMI 85% or higher are overweight, is seen as overweight, and the 90% or higher is defined as obesity. And we checked that the association with the onset of the thyroid cancer, and the control was 200,000, and the overweight 20,000, and obesity 14,000. And you see that age, gender, and the external radiation doses. With the obesity, the risk ratio was 2.23, which is very high. And even after the adjustment, independent risk factor is pointed out for this group. So there is a possibility of the association with of the thyroid cancer and the obesity. And this is the summary, the finding from the TUE. And the relationship between radiation exposure dose and thyroid cancer, at this point of time, there is no statistically significant dose-response relationship. And secondly, the confounding factors association. And the participation ratio of the exam and the age, gender, and obesity are pointed out as a possible factor for the confounding. Lastly, the current status and the future of TUE. And this is outline of the TUE. The fifth round from 2020 to 2023 till March, it was conducted. And currently, it is in the sixth round and started from April 2023. And I talked about the advantage and disadvantage of TUE. This is a voluntary examination. So the eligible people are people who want to have this examination. And the people who want this examination, for them, we are setting up the system so that they can get the examination in a very easy manner. And the general venue, including the evenings and holidays and public facilities, and we would like to make it possible to apply via web so that the convenience is improved for the application. And currently in a medical institution, there are 85 in-prefecture institutions and 146 out-of-prefecture institutions. And as of last year, so it is possible to have the examination in these medical institutions. As a disadvantage is that there should be the concern, accelerated concern or anxiety. In order to mitigate that, the support team enhancement is now being worked, and we would like to continue to work on that. More specifically, the point is the psychosocial support. Right after the primary exam, at the same venue, the explanation can be given from the doctor. And the confirmatory examination, and this is the exam that something is pointed out in the primary testing, and support team, and also that the clinical psychologists are the members of the team so that they can respond to the anxiety of the people at the same venue. And secondly, it is a medical consultation line. So to the medical related question, the doctors are able to respond and answer the questions. And the on-site lectures and the session, and between 2013 and 2023, it was conducted in 306 sites. And also the medical expense support from Fukushima Prefecture. This is the prefectural work. So the financial burden of the medical expenses, as a part of the prefectural business, the support is provided so that the disadvantage of the exam can be reduced for TUE. So this is the last slide. For this research and the survey, Radiation Medical Science Center doctors and also the staff members at this center have been very supportive. And these are the people who made it possible for me to present this material. And I'd like to once again extend acknowledgement to them. Thank you very much for your kind attention. Thank you very much, Dr. Furuya. And please raise a question in the format I explained.
Title of the presentation is Lessons from 12 Years of the Comprehensive Health Check. Dr. Shimabukuro of FMU to present. Over to you, Dr. Shimabukuro. Good afternoon. I am from FMU. My name is Shimabukuro. Session 1-3, Lessons from 12 Years of the Comprehensive Health Check. Topics. There are 3 topics. 1, lessons from 12 years of the CHC. So I'd like to talk about the lessons. there has been some changes observed. So topics number 2, possible mechanisms, will be explained. And also as topic 3, let me share future perspectives based on the health check result. This is how FHMS is constructed. In this study, I will cover basic survey and CHC 1 and 3. Estimated radiation dose and NCD, how they are related with each other. The background. In the basic survey, we have obtained estimated dose of 4 months after the 2011 Greatest Japan earthquake. And we estimated doses. We also, the purpose of the study is to determine the relationship between estimated radiation doses and NCD in the resident in the 13 municipalities. The colored area is the designated evacuation zone where we measured air dose rate and estimated doses. And we, those who had basic survey were eligible. And out of 70,869, we covered 54,087 people. And we divided these residents into 3 groups: 1021, 122, and 2 and over millisievert. And also looked at onset of NCDs and looked at how estimated radiation dose impact the onset of NCD. Result. Out of 28,000 residents, 68%, 25%, and 7% are the grouping result. They make up of 57%. So the remaining 47% estimated dose is not known, but we used a method called multiple imputation to calculate the estimated dose of the non-participants. And later I will show you the details. And we also analyzed the basic survey group and no basic survey group and the basic survey group alone. The result. This list for the hypertension, diabetes, and dyslipidemia and other NCDs. And polycythemia, anemia, thrombocytopenia, and lymphocytopenia are the diseases that might be influenced by the exposure to the radiation. And this table shows that the increase of such diseases in a group of radiation dose of 2 millisievert per year or higher. And if the figure is over 1, it means that it has increased. And for example, in hypertension, in this group, the figure increases 1.29 means that the 2 millisievert group has 29% increase in the occurrence of hypertension. And then we adjust the model with sex and age and BMI and evacuation status, and it still increased by 13%. And then we adjust it with excessive drinking and smoking, and then the impact disappears. And diabetes and others, in model 1, increase has been indicated. But after the adjustment with other risk factors, other factors, it disappears. Summary. Estimated doses were associated with increased hypertension, diabetes, and up to polycythemia. However, the association disappeared after adjustment for evacuation status and lifestyle-related factors. As a result, it is unlikely that the high estimated dose of the evacuees in the first 4 months were directly related to the onset of lifestyle-related diseases. On the other hand, it is presumed that evacuation and lifestyle changes have affected the development of NCD among residents. However, there are limitations on the study. The coverage ratio is only 30%, so it might not represent the population as a whole. And so another limitation is that since CHC was initiated several months after the accident, that might not reflect the effect of radiation exposure well enough. And also, it requires longer follow-up, and this study's follow-up period is 60 years at the maximum, and also the effect of diet, physical activity, and psychological stress are not considered. Next, let me talk about the possible mechanism. This shows how NCD occurs in general. And the representative NCDs are diabetes and hypertension and IgT, but they normally do not exhibit symptoms. But it would result in the arterial fibrillation and stroke and myocardial infarction and CKD that will trouble them and present symptoms. One of the well-known causes is behavioral risk factors such as unhealthy diet. But another factors are at work, for example, globalization, urbanization, and air pollution, for example. Other than that, there are some learnings from CHC for 50-year-old or younger children, and in this group, a certain number of children presented obesity, dyslipidemia, hyperuricemia, liver dysfunction, and hypertension and IgT. And fortunately, obesity improved, however, dyslipidemia among boys persisted. For the population 16-year-old or higher, obesity, metabolic syndrome, IgT and diabetes, and CKD, hyperuricemia, and polycythemia increased. Hypertension and LDL, cholesterol, liver dysfunction improved due to the therapy and higher physical activity. And no changes were observed in the white blood cell count and functions. This diagram shows the increasing NCD after the disaster and how the evacuation is impacted. And we show the graph with the ones related to obesity, the ones are not related to obesity. And it starts with visceral obesity, and then it proceeds to high triglyceride, low HDL, and hypertension and IGT. And when IGT person develop diabetes, the same percentage of MCD would take place if the person is not obese, and then CKD might take place, and hypertension might take place. And I underscored those which has been increased in the CHC, for example, diabetes and metabolic syndrome and IGT, especially among adults. And hyperuricemia is on the rise as well. And for the diseases I have explained, we are now conducting a detailed study, and for example, in CKD. This table explains in what group CKD, NCD increased, and red means that there is an increase in the group in the NCD, and downside arrow means there was a decrease. Hypertension, for example, increase both of the men and women, but you can clearly see the association with obesity. In all the hypertension, diabetes, dyslipidemia, and liver dysfunction and CKD had an increase both in men and women. If the person smokes, leanness increase, and if smoking is present, dyslipidemia might increase among men as well as diabetes. Evacuation status might affect dyslipidemia and liver dysfunction, and changes of jobs will increase dyslipidemia and liver dysfunction. Based on the result, what is the future perspectives? What we can do in order to protect the health of the residents? How NCD occurs at the top. What we can do as an individual. Not only yourself, but also your family members. First, it's important to keep to healthy lifestyle. You have to get an accurate knowledge of the importance as well, or literacy. Health literacy is very important. What you can do as an individual is quite limited, so it is important to take an action in community, country, and as well as the global level. For example, in a community level, you cannot ensure good health if only junk foods are available. So it's important to offer healthy food and offer places and times for physical activities. Right after the disaster, people didn't have enough opportunity to exercise, for example. It's important to offer place and times. Also, it's important to create systems to support NCD prevention and care services. On a country level, it's important to offer opportunities for health check and provide research support. Our health management survey is expected of these things. So what can we do? What are the evidence for prevention and treatment? If the person is over 50-year-old and unhealthy and physically inactive, and or if the person is adult, it's important to overcome improve the obesity. And to do so, there is no effective medication. It's important to lose weight. But once you have developed diabetes, there are specific comorbidities such as diabetic retinopathy, neuropathy, and nephropathy. You might think that losing weight might improve the status of such diabetic microangiopathy. However, it would not. So you have to take medication. There are non-obesity related risk factors you can see at the bottom. Losing weight is not effective for LDL cholesterol figure. You need to take medication to improve. To hypertension, losing weight is not effective. You have to restrict the salt intake and take medication. This slide lists up the loss of CHC in 10 years. 5 major points. I would not go into detail, but it is important to give a feedback to the resident if they take CHC. It is also important to share the feedback with municipalities and to identify where the difficulty lies so that they can make an individual approach. To deliver that message to the residents, it's important to have face-to-face communications as well. And by such communication, we can reduce risk to a substantial level. However, for the increase of diabetes and hypertension, the risk will grow larger with the passage of time, so we have to take further action. Summary. So what we learned in the 12 years of a comprehensive health check and possible mechanism and future perspectives. Thank you so much for your attention. Thank you, Dr. Shimabukuro, for your presentation.
Yes, let's go to the fourth topics. The current issues of mental health among affected people after Fukushima disaster, the importance of human bonds in society. Dr. Horikoshi Naoko, who is the Deputy Director of the Mental Health and Lifestyle Survey at FMU. So would you please refer to page 24 and 25 for her biography. So Dr. Horikoshi, are you ready? Would you please begin your part? Thank you very much for your introduction. I will focus on I will present on Kokokara survey, mental health and also lifestyle survey. or MHLS. The topic today is current issues of mental health among affected people after the Fukushima disaster, the importance of human bonds in society. I will focus on the overview in the past year in the first part, and also I will focus on the support we are offering from the bond or connection in the latter part of my presentation. So this is the purpose of the survey, or MHLS. So through the survey, we wanted to understand the mental health and lifestyle problems of the people affected by the disaster on a long-term basis. Then based on the health information we obtain, providing appropriate support for their health, medical care, and welfare to fulfill their needs, such as reaching out to them via telephone call. In other words, the purpose of MHLS was not only to conduct a survey, but also to provide support. So about 13 cities, or the 210,000 residents, were covered in this survey. Based on the age, we have divided the questions into 5 groups, and we have sent this question to individual, not to each family. And this survey started in January 2012, and this is our year 13. The main survey items are that the strength and the disabilities questionnaire, or SDQ, subject health, sleep, exercise, and development, and so forth for the children under junior high school age. And these were mainly answered by their parents, but only junior high school students were asked to answer some of the questions by themselves. For adults, we asked the questions about the general mental health, trauma, medical history, diet, radiation risk, perception, and so forth. And also, we included a space for free descriptions. We received over 40,000 responses per year, and we read all the free descriptions as the voice of people affected by the disaster. Now, let me explain the result of the survey. So first is the response rate, how it was developed. For children, in the first year, 63.4%, adults, 40.7%. The response rates have been high, but since then, it went down slightly, step by step, and 20% below for children now. And for adults, it has been remained at the range of 20%. So we found many voices that they wanted answer online. So from 2016, people can answer either by online or by paper. Overall, among the overall responses, about 30% of children and also 15% of adults have responded online. Next, I want to show you the result of SDQ, the proportion of children with 16 points or higher. So unaffected people's average was 9.5% for the unaffected area, people living in unaffected areas. However, immediately after the earthquake, the rate was much higher for all ages, especially for children aged 4 to 6 at 24.4%. Since then, the rate has decreased in all age groups. And it has been over 10 years after the earthquake, and maybe one of the reasons of the improvement was we have more children who did not experience the earthquake. Now I want to show the result from the adults. So the feeling depression and also the feeling anxiety, we have the people with the risk having a higher risk scores. And 30% that was before the earthquake, and after the earthquake it went up to 14.5%, and it was gradually improving after that. But in FY 2021, it was increased about 1%, probably due to COVID-19. Next is about daily exercise frequency, almost every day or rarely. So we have 4 ranges, and people who exercise often, the proportion has been improved since the disaster. However, maybe because of COVID in 2021, the people who did not exercise, the proportion went up slightly. This is about problematic drinking. From 2012, we added this item, so that highly likely that people having problematic drinking, that the score, that the ratio has gone down for both male and also female. Next is about changes in the risk perception of next generation radiation effects, like your children or grandchildren, how much health impact could occur by the radiation effect. And probably we had 4 levels. Probabilities are very low to probabilities are very high. The people who answered possibilities are high and very high have been decreasing step by step each year. Whether they are living in Fukushima Prefecture or outside of the prefecture, people who are living outside the prefecture, in their perception, the score was higher. That they think there is a probability of risk. Next is that if you have any mental or physical problem, do you have anyone who you can contact with? And who said yes? Among that, the highest who they consulted to, the majority was the highest answer was family, then friends, and so forth. But 11% of the people said they don't have anyone to consult with. And who are those people? The people who say yes, that means 11% of the entire population. And they were mainly 40 to 64 years old male and having economic difficulties and living alone. At the same time, the people who don't have the person to consult with, seems like their overall mental health was worse than the people who did have someone to consult with, and they have more people had the problematic drinking too. So the social connection is essential to improve mental health. So. Especially family members in the critical situation, like the disasters as well as daily life. So those are the strongest, the most important supporters. And we have done some survey of the people who don't consult with their family members. The people who don't consult with their family members, compared to the people who consult with the families, the mental health risk is 1.33 times higher. So to the affected people, we need to ask them if they have someone they can consult with. At the same time, we need to check with them if they have been able to consult with their families. It could identify the people with high-risk scores earlier. Now let's move on to the latter part of my presentation. So based on the result of the survey, how we are connecting with affected people, supporters, and also municipalities, I want to talk about this from the viewpoint of connection. Number one, we are offering telephone support based on the outreach approach, and we are not waiting for the telephone calls from them. We are outreaching them by making telephone calls to offer support. So the strength of this approach is that it doesn't matter if they want to consult with us or not. Since we are calling them, the people who cannot seek help by themselves, we can also approach those people. At the same time, we understand the situation from the questionnaires or survey. We can approach to the substantial problem at the earlier stage, and also like a geographical problem. There is no impact from the travel time or travel cost. We can offer prompt the nimble support to the people living in remote areas. The support team includes a clinical psychologist and also public health nurse, and also the social workers. And based on, we do the assessment based on the information from the affected people, and we can refer other centers as needed, and also we can refer them to the regional sources or healthcare facilities. And we have offered this telephone support to 40,000 people people so far. This is a criteria to select the participants of SQD for children, and also if they have any party person they can consult with, and what was described in that free description space. For adults, the overall their mental health status, and also trauma, sleep, drinking, and other information from the free description. And concerning the telephone support, we have done the interview for the people living in the temporary houses, if that screening efficacy was insufficient. And this was why, because I came to Fukushima from Kanagawa Prefecture. This is, I remember this clearly. So, you know, that the people who conducted survey were like public health nurses. And I'm so thankful that there were so many supporters came from Fukushima prefectures and also other prefectures to offer support. And there are some members who are staying here to keep offering support. And so the majority of those supporters were for their first time to visit affected areas. So we took them a tour to take a look at the actually affected areas by tsunami, and we asked them to bring the map of Fukushima prefecture and also brought a pressure monitor. And the map are so useful for the surveyors who were not familiar with the area, and at the same time they were able to keep measuring blood pressure, their blood pressure, and at the same time they were able to offer support and advices to the affected people. And they are specialists, because the health nurses are specialists as surveyors. That was one of the positive impact as well. And this is a very large scale question survey based on questionnaire, but we have done interviews too, and we were able to have opportunity to listen to the voices of affected people directly about their living status. I think that was a very important experience for us. And also that we have done the outreach telephone support impression evaluation too. The satisfaction level of our support was 74.6% for outreach style approach, and we are supporting about 3,000 people each year. Sometimes people say showed their appreciation, and some people were mad at us. However, we had limited manpower, but we were able to support so many people because of this outreach approach, offering the telephone support. Now, the connection with the different types of supporters. So telephone support, we don't have face-to-face meeting with the people. So we have an opportunity to share the information. If we can have a face-to-face meeting among us, then it's very important to take quick action, especially the people who are living in affected by the disaster in prefecture. Now they are spread across the country, so they need to have a good connection with the public offices of other prefectures too, especially municipalities in the afflicted area. That is a very important connection to the affected people. So I want to introduce the following concerning. And we need to have municipalities to understand affected people, our survey, and asking their residents to respond. And also we try to incorporate the intention of each municipality too, and so that concerning the question about if they have people to consult with, that was requested by the public health nurse from the municipality. And also we have a communication meeting with affected 13 cities in order to exchange information on a regular basis. And we want to offer continuous support to the affected people having some problems, and based on the information we obtained from the telephone support, sometimes we visit their homes too. And also the article we post in our PL magazines and so forth, and we capitalize utilizing the accumulated data in the effective way. Next is about the long-term support. And there were people who were able to respond to the survey for the first time after 10 years since the disaster too. Since this is a long-term initiative, so that we were able to get responses from those people too. We still have people who have not responded to the survey. That's a remaining challenge. I understand that they are socially isolated and they have a high level of psychological stress. So that's why, and as a specific measure, we are offering consultation support, not only the outreach approach, but also just waiting for the phone call from those people. At the same time, we have a list of telephone numbers which is inserted into the questionnaire so that they can call those numbers seeking for support. And also we are sending a leaflet to disseminate health-related information and promoting healthcare to take good care of their health. And that it's very important to send a message that we really care about each person. This is a summary. The disaster occurred in Fukushima. That's not about somebody else. So it doesn't matter. There is disaster risk in any region. Doesn't matter if they have a nuclear power plant or not. So the affected people said that please do not forget our struggle. So we need to be aware of the necessity to be prepared for that disaster in that on a day-to-day basis, and that affected people in Fukushima understand their the physical and also mental health conditions are recovering step by step. However, we still have 27,000 people being evacuated. So we know there's so much we can do as individual. However, we have supported 40,000 people through the telephone support, and we want to stay close to the affected people going forward as well, together with the staff members of MHLS. And last but not least, I sincerely wish that the recovery, that the reconstruction and rehabilitation in that affected areas in Noto Peninsula due to the earthquake as soon as possible. Thank you very much, Dr. Horikoshi. So this MHLS survey, this is not about survey only. Their purpose is to offer support too. And this kind of survey and support can be applied to other types of disasters too. I think that was a message which was delivered clearly. Next.
Fifth presentation in this section about the pregnancy and the birth survey in Fukushima Prefecture about changes of the spontaneous and the induced abortion in Fukushima Prefecture. And he is also the head of the pregnancy support office. And page 26 and 27 describes more detail about his background. If you are ready, please start. My name is Fujimori from Fukushima Medical University. Thank you. And I'm a director of pregnancy and birth survey. So for this survey and the support for the pregnant woman in Fukushima Prefecture, as that the FHMS as a main survey for 10 years, we have conducted a survey on the pregnancy and birth. And now, as a main survey, it is no longer conducted. And secondly, as a follow-up survey, after that, the birth or postpartum, 4 years of postpartum, we believe it is necessary to provide extra support. So from 2011 to 2014, the first round follow-up survey was conducted, and the second round, that is at the time of 8 years postpartum, and for the women who had the delivery after 4 years of the disaster. And number 3, actually, that this survey is for the people who have the note for the baby and the mother, but there are some cases that abortion happened before that period, and in order to supplement that, before they are getting that the mother and child and notebook, we have done the survey of the spontaneous induced abortion. Number 4, there is a Japan Association of Obstetric and Gynecology, and they have more than 1,000 of the monitoring in the last 50 years. And they were mainly done by the large-size hospitals, but we made a request so that in Fukushima Prefecture, the monitoring was done by all hospitals. And it is not a part of my presentation this time, but we are conducting this kind of survey too. And as I mentioned, and this slide was shared, and this survey that has that part of the detailed survey. And this is the outline. And for this booklet is provided by the municipality, and the municipality understand that the address of the mother, and our center received that address information, and using this address, we send out the questionnaire sheet, and the covered population fill in the form or they respond online. And looking at the contents for the free comment part, and we determine whether the telephone support or face-to-face support are necessary. And if necessary, then that psychosocial support team will take the role. And we sometimes connect those people to the municipalities so that the municipality can directly send that they provide the support for them. And this is the number of those covered population, and the bar graph shows you who gave the birth in the Fukushima Prefecture. Right after the disaster, it went down, and there are some declining tendency, but this is not the tendency limited to Fukushima Prefecture. And the bottom, you see that the national figures and the same tendency is observed. So this response rate, 58% was the response rate, which was very high in the beginning, but afterwards it is staying around 50%. I believe they were very proactive to respond to us filling the questionnaire. This is the preterm delivery rate. And the red shows you that the national average, and the blue shows you that the result we gained from this survey. It didn't go above the national average. And also the low birth weight infant rate. The baby who are born very small, the red is the national average, and the blue is the data from Fukushima Prefecture. There are some higher area, but in general, they are not so different from the national data or even lower compared to the national data. And also the congenital anomalies and birth defect. The blue is a result of this survey. In general, the babies, they usually have some kind of abnormal condition. For 2 to 3% of all babies who are born. And looking at this number, Fukushima Prefecture, 2 to 3% are the range. And among the congenital anomalies, most of the majority is cardiac abnormality. It's about 1%. So it is only limited to the cardiac abnormality, and it is staying around 1%. And also, this is the mental health of mothers and depressive tendency. So it is not a diagnosed depression, but the depressive tendencies, we measure them with the two different items, and generally, EPDS, edible postnatal depressive system, this is usually used. However, the questions were so many, we used these two indicators in this survey, and we asked the mother to respond. Right after the disaster, there was a very high depressive tendencies. The green shows you that it's converted to EPDS. And there is a paper to show the calculation, but after the conversion, this is it. But over time, we are seeing the declining trend of the people with the depressive tendencies converted to EPSG and the EPDS, and 9.7% on the national data is shown. And the people who had the birth, who gave the birth in Fukushima, went down to about the same level as the national average. And the top three topics in the free ride section. In the first section, the radiation effect was the concern of a lot of mothers, and over time it went down. After 2015, the natural mothers' worries, such as the child rearing and the mothers' concern about their bodies, and those are the items that they were worried about, which is quite natural. And the effects on the radiation on fetus and child is described at the bottom. And over time, it is going down, as you can see. And the last 10th year 10, it went down to 0.5%. And the follow-up survey, as I said, and 4 years and 8 years after the delivery, we do this survey. And the people who are covered, and to the respondents, we are doing the survey, and the response rate is high 30s to 40%. So this is the postcard we do the survey on, and it is a simple format to just give the check mark. And the depressive tendency. And the first year, the year of the disaster, the mothers who gave birth had high depressive tendency, but 2014 and 2018, unfortunately, year 8 had high figures, probably because of the COVID, concern over COVID. And this is a free format answers. And again, the follow-up survey, even if it is a follow-up survey, the people who had the babies in the same year of the disaster and next year, the mothers are worried about the impact of the radiation to their children. And next, the basic survey. As a part of the basic survey, this is the external exposure, external radiation dose, and also relationship to congenital anomalies. And you see the data of the age and so on, and the weight at the time of birth, SGA, small gestational age. So the smaller the 1% percentile of the lower weight of the ordinary weight. So in any of these items, there was no correlation to the external radiation dose. So external radiation doses and the congenital malformations relationship. And cataract, neural tube defects, microcephaly are often talked about, but we didn't find any correlation, especially 2 millisievert or higher exposure. The people who have such exposure, they show no abnormalities or malformations. And this is a summary. The dependence, the depressive tendency is going down, and it was 18% in 2020 and 10% after converting to Edinburgh method, and it is getting close to the national average. And people who are worried about the impact of the radiation is going down, and it was 0.5% in 2020. And follow-up survey, it was going down, and there was some increase in the year 8, and probably this is due to the COVID-19 and the doses association with abnormality were not found. And this in our office, so this is the result of the survey we have conducted, the result of the spontaneous induced abortion and the event. So this is the time that, and so what was the outcome when the mothers become pregnant? And what happened afterwards is how you look at this chart. And if it is within this range, it is not significant difference. And the spontaneous abortion rate, it is about 10 to 15% of the spontaneous abortion out of the all pregnancy, and it is about 10%. There was no significant change. Regarding the induced abortion, right after the disaster, looking at the Fukushima as a whole, there may be a slight increase, and the mass media was pointing out, but after doing the analysis for 6 years, and this is a month of event, and we do the analysis every 3 months. And at the time of 4, there is a periodic characteristic. So every year, there is. It shows you that there's a certain month you see the increase every year, and for this, you can say this as the gestation, meaning the May has particularly high rate of the induced abortion. There is no specificity in terms of the increase, but and there is a likelihood the periodicity result overlaps. Is overlapped with the earthquake incident, and actually I've been using the same slide since the time just after the disaster. So this is the safety discussion cannot always lead to the security of the people's mind. So we would like to disclose the objective scientific data so that we can show the people that Fukushima is safe. Thank you very much for your kind attention. Dr. Fujimori, thank you very much. From this survey and of this pregnancy, and there was no impact on the babies, but there is a tendency of the depression. But after 10 years, it went back to the normal level. So the depressive tendency continued for 10 years, and that was very something I learned from this presentation. And if you have a question, please enter your question up to 12:25. Then, based on the questions, we would like to ask the presenter to answer those questions. Thank you very much.
Now, allow me to start the discussion session 1. Let me invite the chair, Dr. Shimura and Dr. Ohira. First, let me thank you for your sending so many questions. Since there are so many questions, let me pick up the questions that were asked by more than one people, and also the questions that seems to be highly relevant to the discussion. I'd like now Dr. Ishikawa to take the questions. There are so many questions about evaluation of internal exposure dose. The current status of internal exposure, how to evaluate them, and how to evaluate internal exposure going forward. And another field that attracted a lot of questions is about food. Thank you, and thank you for the questions. How to evaluate the internal exposure in thyroid? There is one page in my slide deck that summarizes how to. One thing is the behavioral record in basic survey, and also what we got done in simulation, the radiation condensation in air and water. By analyzing these indicators, you can exposure absorption to thyroid and exposure taken by food and water. Regarding the evaluation methodology, what seems to be most reliable is the figure right after the disaster, which accumulated in the thyroid. You apply the dosimeter to the thyroid and evaluate. That evaluation is considered to be most reliable. However, we have the data of only 1,000 residents measured by that methodology. So that's the direct method, and we also have our own method, and compare the result and confirm that they both produce a similar value. And then we are now somewhat confident that our method is applicable to larger population, and that's why we decided to use the simulation and behavioral record method. Your question, the other popular question was about the food. As you mentioned, inhalation of air and route by water is also considered. And regarding the food, the accident took place in March, and not so much vegetables were in the market that were grown outdoors. So it's hard to evaluate its impact. And the most important thing is the most reliable measure is the direct method. And also the result is somewhat similar to the other conventional method. The report is also published as an academic paper. It's peer-reviewed. And therefore, I am confident that our method is somewhat reasonable. That's it from me. Thank you. There are some restrictions in the food sample that you were able to obtain, right? Yes, that's right. I forgot to mention that. That's another important point. Oh, I forgot to mention though. Okay. Next, let me ask questions to Dr. Furuya. So let me ask the question to Dr. Furuya. Estimated dose data and thyroid cancer risk data. You presented these two data. How did you consider the internal exposure dose in these items? Thank you so much for your question. I would like to answer. The case control survey I conducted and presented in the presentation for internal exposure, we take samples from the tap water 14 days of the accident and other method. And for the external exposure, we applied the correction factor of 1.1 and estimate the radiation dose, and that's what I used in my case control study. So you also considered the estimated internal exposure dose in your case control study. Okay, thank you. All right, then I'd like to ask questions to Dr. Shimabukuro. One of the popular questions was NCDs, for example, hypertension, and the association with radiation dose was your topic. In hypertension, when our age and sex is adjusted, then the occurrence of hypertension is significantly higher in 2 millisievert group. However, after adjustment with the lifestyle, the association disappeared, you said. Could you elaborate on that? For the groups with the exposure of 2 millisievert or higher, how does it associate with the higher incidence of hypertension? Thank you for your question. Such as hypertension and dyslipidemia and diabetes, and the group showed a higher incidence. That's very important. And on the other hand, evacuation status and increasing drinking and smoking behavior, when these factors are adjusted in the model, then the association disappears. That's what the statistics shows. And I understand that we still be careful in interpretation of this data. But the important point is the dose of 2 millisievert or higher is not the factor. The factor is the fact that they had to evacuate as a result of possible high dose of 2 millisievert. I am not 100% sure that this is the determinant from a scientific viewpoint. But although I can say that it is not of statistical significance, we cannot completely rule out the possibility. That's why I consider that we have to continue looking it carefully. Thank you. At the moment, you can deny the association after model adjustment. However, the impact of the evacuation and those on NCD need to be monitored in an extended period of time, right? Yes. From here, now, may I direct the questions to Dr. Horikoshi, who conducted the MHLS. What are the actions that the municipality and the government needed to take before the disaster hit you? Thank you so much for your question. It's about the general readiness, and each municipality has the disaster plan already. So I interpret you ask what else they can do. We've got accumulated data, but the data regarding the period after the disaster. We understand what is the number of evacuees long term, but desirably, you have to capture the mental state of the evacuees. If you know the status of mental health of the resident before the accident hit you, then you can compare pre and post disaster status. Unfortunately, we didn't have pre-disaster mental health data, so we had to rely on nationwide database. If you could pay attention to mental health status data before the disaster, that would help you if in the event of the disaster. Thank you so much for your response. MHLS actually started after the disaster, so it's impossible for you to compare pre and post disaster status. So you can say that those having a mental issue is on the rise and depressed on the rise. However, you cannot compare and contrast it to the pre-disaster status. So it's important to measure it periodically so that you can use the data when an event occurs. Thank you. Thank you so much.
Then next is about the survey for pregnant women. Dr. Fujimori, there is a question to him. So the result of the survey among pregnant women. So in the beginning, response rate was 58%, but in the following period, many cases it was below 50% or even in the range of 40%. So remaining people who did not respond, you don't have the data of those people. This is a question about the issue of representativeness. The data comparing with national data, if you just focus on the 50% of the data you have, maybe this is going to be pointless. The people who why don't you don't get the data from the healthcare institutions within the prefecture where people deliver babies? Thank you for the question. When we started this survey, we wanted to focus not only on the survey but also support. That was the goal given to us. If we do the survey among the institutions, healthcare institutions, we won't be able to take care of individual pregnant women. That's why we wanted to use the system to distribute questionnaires so that we can get the answer from each individual, so that we can offer necessary support to them. So because of that, we decided to take this approach. So the respondents, it was around 50% of the total people we sent a questionnaire to. But as a response rate of the survey, I think this is a relatively high ratio. That's my personal view. But why we don't conduct like 100% survey covering all the healthcare institutions? We did not talk about it. There is a society of gynecology, and they have done the in congenital diseases, and we asked them. In Fukushima Prefecture, we did 100% survey, and as you asked, the questionnaire was sent to each healthcare institution, and the survey was conducted among everyone, all the pregnant women, 100%. And I have seen the interim result of the survey. There was no increase in abnormalities specific to Fukushima Prefecture. That's all I was able to confirm that today. And as we discussed today, the abortion and also this miscarriage of a baby, we were not able to cover in my presentation, but we have done the survey among healthcare institutions, the number of pregnant women, and also abortion, and also miscarriage, and about 60 healthcare institutions within Fukushima Prefecture, and the collection rate was 100%. That's all from my side. Thank you very much. So apart from FHMS, from the another survey from covered all the healthcare institutions, so he answered based on that background. So going back to Dr. Ishikawa again. Okay, I want to ask him a question. I want to share the question to him. So first of all, the basic survey, the external exposure dose, the assessment on that, is it reasonable? Was it appropriate? So appropriateness of that radiation dose assessment or estimation. Do you have anything you can comment, Dr. Ishikawa? Thank you for the question. So external dose assessment method we applied in basic survey. Again, peer review, we have already publicized a scientific paper which was reviewed by our peers. So the method was appropriate. That was written in the paper after peer review. So scientifically, it was appropriate. So that's my view. That's the first point. The second point is, with our method, we used behavioral record and also that airborne dose, and we have the map, and based on the actually measured the ambient dose, and we have used both pieces of data to do the assessment. We have another method like unscare. So air dose, not the actual dose measured in the air, but the radioactive substance which was accumulated in the soil, and use that. And they have used the calculation method using both pieces of data and also like a behavior or activity patterns. Those are all of those were used to analyze the external radiation dose. And our result and also unscares dose estimate, we adapted different methods to do the assessment. However, roughly, mostly it was appropriate or it was aligned. So we did not identify any major difference. So theoretically, as a methodology, it was appropriate. That's one point. And also unscare used the method, and comparing to their method, we did not find big difference or a contradiction. I have a follow-up question. In unscare, internal radiation dose, and also that how many the dose in the thyroid gland dose, I think that was also evaluated, and we got a lot of questions too. I understand it was not covered in your presentation. Maybe you won't be able to give a clear answer to that, but do you have any view on this? Thank you for the questions. There is an overlap with my earlier answer, but the method we used and we have that behavior record we got from the basic survey, and also that measured dose in the air or water. We used both pieces of data in order to evaluate the internal dose. At the same time, most reliable data we think is that accumulated radioactive substance in the thyroid gland direct measurement method, and we did not find a big difference. So those results were more or less the same. Using the average data from municipalities and distributions, we did not identify any big difference. So our method was somewhat inappropriate. So that's our view. That's all. My sincere apologies, but we won't be able to take questions from the venue. So our sincere apologies. Next, Dr. Furuya. About the dose and also the odds ratio between the dose and also that the thyroid gland cancer, that we have seen that that it was increasing. You said there is no significant or that strong relationship between those two, but what do you think about the data you presented? Because it has been going higher and higher. Maybe it's difficult for you to answer, but I want to ask you. Thank you very much for the question. So in the case of the control study, I presented an equivalent dose in the thyroid gland, 3 ml sievert, and also between 3 to 12 and over 12. There were 3 groups for the study. So 3 ml sievert odds ratio was 1. It was, it looks like it was flattish, but looking into the details for between 3 to 12 and also like after over 12 mil sievert, maybe there is an increase, but the answer is there was no remarkable difference from the significant difference from the statistic viewpoint. So that will be my key answer to your question. But we do need to do prudently work on this. So concerning that, we have adjustment factor, and adjustment was made using that factor in this result. But as it was covered in my presentation, like gender and date of birth, and also examination frequencies, how many times they had the examinations, and we are using all the information we were able to obtain in order to analyze this. So I am repeating myself, but based on the analysis we have done, there was no significant difference from the statistic viewpoint. About the confirmatory survey done, like regional difference, and also the difference in cytology, and the cases number of cytologies conducted. Was it adjusted? Actually, there are other factors which can impact the result of the survey, but those factors which we cannot adjust, then we are treating those as unadjustable factors. But going forward, we are going to further discuss this, and I think that's needed. So we would like to further, work on this going forward. So you have shared the data as of today. So that was the interpretation based on the data we have. Thank you very much. And going to a question about CHC. This is a question to Dr. Shimabukuro. Chernobyl, after the accident of the nuclear power plant, and that the more people having diabetes, not only the change in lifestyle and also the change due to the exposure to radiation, was it taken into consideration? Thank you very much for the question. So Chernobyl, a nuclear power plant, And yes, it was observed, it was an increase among the people living in that region. And as a result, there was a change in lifestyle. Of course, we need to assume there was a lifestyle change and also the change due to the exposure to radiation, including major natural disaster. And it's obviously it increases. For example, there was a big earthquake, and that there was an increase in the same data too. So as I showed you today in our data too, so that we have seen more diabetes. So the prevalence rate increased. So there was the same data obtained. So maybe the question was if it was impacted by the radiation dose. Of course, we don't deny that possibility from the beginning. That possibility was taken into consideration in our survey too. So 2 millisieverts and above people with that dose. So without the adjustment, there was an increase, but the impact from evacuation, and if you adjust that based on that, then there is no difference. So the impact from the evacuation was a big influence. So, and I think that can explain most of that. However, as it was in your question, can we deny it completely? I think that was a point of the question. And of course, such impact, we did not ignore such an impact. We want to do more research. And as of today, we did not identify any relationship between those. So we want to see this from the long-term perspective.
Thank you very much. And the additional question, the stress, impact from the stress can be seen as an onset of the diabetes. But in this survey, have you done the research between the relationship between the diabetes and stress? It is quite important point. On the total society level, not so many studies have done the research on the relationship, but we have the major finding. If we follow up the patient for 7 years, we see the tendency of increasing the diabetes for the evacuees. And what's interesting is that between women and men, the men only shows the increased stress, and that tendency is not observed among women. So along with the evacuation, the stress, there is an impact of the stress, and that is, and the men are more receptive for that. And the reason for that, and generally speaking, and women have more stress. That is known widely among Japanese and also non-Japanese. But what we are thinking is that the women feel stress more and can respond to that. But for men, it is difficult to show they have a stress, even if there is a questionnaire survey. And when they say there is a stress, then the seriousness is really high. So that should be affecting the result of men having more stress. And because of the stress, the overeating and overdrinking, and which can lead to the diabetes, is what we are seeing, and that is our assumption. And thank you very much for that. And next question. And Dr. Horikoshi, question for you. Like you do the survey, when you provide the support, securing the people who provide the support, if you pay special attention to that, please share with us. That the securing that the doctor who provide the support, in the beginning, I wasn't involved, but I hear it was very difficult to have the doctors who provide the support. In general, in and out of a prefecture, there were requests given to the medical institutions, but the personal network was prioritized, and the acquaintance of those network, because of the personal connections, we could invite the external people to provide the support. And And afterwards, if it is limited within the prefecture, we don't find so many people who can provide the support psychologically. So we had many external support. But a few years ago, we finally came to the stage that we can manage the people from Fukushima. But the public health nurse and the psychologist are specialists. They are specialists to people, but right after the disaster, the providing the telephone support, the fatigue of the people affected and the anger are often expressed over the phone. And to the anger that brought to them, and they have to respond to them as a professional. And those support providers had a high level of stress. So, of course, we have to be mindful of the support to the affected people, but it was also important to provide the support for the doctors and the healthcare professionals. And we had some encouragement among the peers and the doctors, and also the opinions that the anger is not to them as the professional, but the general anger came from the disaster. Yes, even though you want to provide the support, sometimes you can get accused from the people you want to save, but they can be your personal view. But how can you keep the motivation? Is there any suggestion for that? The motivation for the telephone supporter, that supporting doctors have to get together so that they often talk about the issues, and that's very contributing the higher motivation. Not only the anger, but as I presented through the phone, sometimes they say, "I was so glad that you listened to me." And the words of appreciation are often expressed too, from the evacuees, and that is also contributing to the motivation. So the people providing the telephone support is doing the job for a long time. I think those are the factors really encouraging the continuation of the job. And this is the question to Dr. Fujimori. And there is a conclusion. There is no relationship with the exposure, radiation exposure dose, and also congenital abnormality. But it is not widely known. Why is it? Is it difficult to distribute or send this kind of information for the non-relevant target? And because we confirm not much difference from the ordinary people, we could confirm much difference. But the postpartum depression trend is going down, and to the level equivalent to the national level. So in the initial stage, we were focusing on the support to the pregnant women. And since we could confirm that the support was provided, and so we ended our program after 10 years. And why it's not well known, after the disaster, I think it was a sixth year or seventh year, up to that point, 5 locations in Fukushima every year, I and the Secretariat visited and talked to the public health nurses and also the midwives and nurses, and we asked them to get together. And with such audience, we reported the result of our survey. And annually, we have a training course for the midwives and public health nurse. And starting from that occasion, the no change of the congenital abnormality was reported even outside of prefecture. And that type of reporting in the media is going down recently because it was all well known. But in the journals, we've been reporting that continuously. But since this data shows no change, that may not be, and that may not cause much interest among the people. And that's all from me. And thank you very much. And since we have some time left, we would like to start the third round. And the question to Dr. Ishikawa, for the all people in the prefecture, how do you do the feedback to all people in the prefecture, the result of your survey, and how do you plan to disseminate the data going forward? And it is like a public, the promotional related question. The feedback to the people in Fukushima, the individual feedback, or for the all people in prefecture, there may be two aspects. For the individual, in my presentation, as I said, to the individual, we are giving the information about the doses that we measured. And for other feedback, for all people in the prefecture, we are reporting the result to the working group. And for instance, in this working group, the media comes and do the interview, and also the doses distribution is introduced at the Fukushima newspaper, and the distribution per municipality was put on the pages of the newspaper. And this is one of the ways that we are giving the feedback to the general public. Another thing, how useful is it, or the result of our survey? For instance, to give you one example, what I heard is that one person, a certain person, and when there was an explosion of the nuclear plant, he or she was outside, and he or she was very concerned because of the exposure. But in the basic survey, based on that the behavior, we are doing the estimation for the doses. When at what time the person was outside, and in what condition. If they can give us that information, we can give the estimated dosage sent back to them. So if someone is concerned, then the dose information can be sent as a feedback, as a scientific feedback. For instance, I don't know if I went through the basic survey, or I don't know, I'm not sure about the doses, and there may be some individual issues or the questions. How do you respond to that? And thank you very much. And the basic survey is still ongoing, and therefore the contact or the door is open. And if you have any question, you can always contact or call the call center. Then we can send out the questionnaire sheet. So if there's something, and our door is always open.
We still have some more minutes, so let me direct the next question to Dr. Furuya. Thyroid cancer and including the suspicious thyroid gland and cyst that we collect FMU, that we call it FHMS. There are some other thyroid cancer cases, and how do you get that data reflected in the whole? As you see, yes, there are thyroid cancers detected outside of FHMS. Based on the possibility in the case control study, we also added cancer registry registrants. This is a nationwide registration system which records the data of cancer patients all throughout Japan, and that the data is reflected in the study that I presented today. And still there are some missing cases, but I'd like you to understand that we have already made an utmost effort to sample thyroid cancers. To analyze causal relationship between radiation and thyroid cancer as accurately as possible. Okay, the answer is that we have made the utmost effort. Okay, now time is up. Let me close this session. Every year we have this international symposium to take your questions while presenting the new data, latest data. And going forward, we will keep in touch with you, continuing explanation. Thank you so much for your participation and attention. This is the end of this session.
So this concludes session 1. Let's acknowledge that based on the volume of questions submitted, 3 days, even 3 hours would be better than 30 minutes. But be assured that the questions that are written down follow us back to Fukushima. And if at subsequent events our presentations get a little better, it's because of the people telling us what they want to know. And we act on those questions. So thank you very much. Now, Ms. Tsuchiya.
Dr. Nolet, please go ahead.
Presentation by Dr. May Abdel Wahab, chaired by Professor Tamaki Tomoaki. Their biographies on pages 30 through 33 show extensive international experience. Professor Tamaki himself was working at the International Atomic Energy Agency when the Fukushima nuclear accident occurred. He subsequently joined FMU in 2015. Dr. Tamaki, the floor is yours.
Thank you very much. My name is Tomoaki Tamaki. I will be chairing the session of this keynote lecture. Today, we have an honor to have our keynote lecturer, Dr. May Abdel Wahab of the IAEA, the Director of Division of Human Health, Department of Nuclear Sciences and Applications of the IAEA. She is an extremely busy person with a lot of projects and tasks internationally. And although she is connecting to us from Vienna, Austria, we are very fortunate to have her presence here online. And we also appreciate that she's accommodating the time difference between Japan and Austria. And I believe it is 6 a.m. in Vienna. And thank you very much, Dr. Abdel Wahab. Can you say just a few words to greet before I introduce your biography?
Thank you very much, Professor Tamaki. It's a pleasure to be here. Friends and esteemed colleagues, can you hear me well?
Yes, we can.
Yes, good. So friends and esteemed colleagues, Professor Tamaki, Professor Yasumura, Professor Oto, and President Takanoshita, we are very happy to work with Fukushima Medical University over the years. We have worked since 2013 together on science, technology studies, and many other areas. The efforts and the excellent programs that have been set up have been a pleasure to collaborate in, and congratulations on having this important meeting and conference, because it's really important, again, for communication. Most of the talk will be regarding how to communicate to each other as human beings, so we can deliver the information, understand each other, regardless of our backgrounds, whether it's scientific or not. And I think that the collaboration has been extremely important. I have been lucky to meet and work with many colleagues and the people of Fukushima who have been inspirational. And today, I wish I could be there myself, but soon, hopefully, I will be able to return and be together, since we are initiating new collaborations as well. I want to thank you for organizing this conference again, and thank you for the kind invitation. It's always a pleasure. So with that, I won't take too much time. I'll hand back to Tamaki Sensei.
Thank you, May. I would briefly introduce the biography of Dr. Abdelwahab. She is a radiation oncologist with an experience of over 30 years of experience of patient care, teaching, research in the field of radiation oncology, with the specialty in the treatment of prostate and gastrointestinal cancers. She has served as a member and chair on various national and international committees, including the United Nations Joint Program on the Cervical Cancer Prevention and Control Steering Committee. She has also led the development and implementation of IAEA Science Technology Society projects in Japan, Asia, and Europe to educate medical doctors in radiation risk communication. She is currently co-leading the IAEA Rays of Hope initiative in a task force aiming to improve access to radiation medicine globally through on-the-ground support to centers, research and innovation and sustainability through anchor centers. Her extensive experiences in research, education, and international cooperation is shown in the page 32 and 33 of the program, so please take a look. With that, we will have pre-recorded lecture of Dr. Abdelwahab to be secure about the broadcasting on site and also online. So after the pre-recorded lecture, she will also answer question and answer sessions. So with that, I would like to start the pre-recorded lecture. じゃあそれでお願いします。
I'd like to thank Fukushima Medical University leaders and organizers for the invitation to speak today. So the areas that we'll cover is a general overview of radiation exposure, how patients are concerned with radiation effects and how they process information, radiation risk assessment, and communication. And then we'll talk about the STS projects, which are the main topic today. And then finally, how the next new STS projects will integrate with Rays of Hope initiative.
Now, an example of proper communication may be as follows. So if you look at this nice infogram, you have a dose scale that shows millisieverts. And then on the right-hand side, you had natural background radiation examples. And then on the left-hand side, you have artificial radiation, and like medical radiation, for example. And so if you tell someone that a certain medical procedure will give them a certain amount of millisievert or expose them, then it's not as easy to understand. However, if you tell them that it's like a Tokyo to New York flight, then it becomes much easier to understand. This is another example of the same kind of concept. So here we can put it in terms of the time to receive equivalent background radiation. So for example, if you get a head CT, it would be the equivalent of 8 months of regular exposure to background radiation. And this puts things in context.
If we look at the anatomy of the brain and the standard functions as we know them, we see that the parietal, frontal, occipital lobe, and cerebellum and their functions, both motor, sensory, and otherwise, on this slide. However, before we go deeper into the communication realm, we must look at the human brain in a developmental way as primate, mammalian, and reptilian brain, or even the neocortex, middle brain, and brainstem, because this classification ties into how we communicate. And when we think of the human brain, there's several levels. If we think of the neocortex versus the middle brain versus the brainstem, each one has specific functions. And unfortunately, in a situation where there is fight and flight response, it usually comes from the lowest part of the brain, which is the brainstem area. So the neocortex, the thoughts, the meaning, the logic go out the window. And we have to remember this when communicating so we can communicate to the person in that state. The level of health literacy cannot be assumed since it varies by socioeconomic status, culture, language, age, ethnicity, education, perception, cognition, but it should not be overlooked since health literacy affects the health outcomes. Why? It can affect access, it can affect utilization, no doubt about it, colors provider-patient interaction and self-care.
So we know that there are gender-specific differences in doctor-patient communication. The differences are not in how much biomedical information is provided to the patients. However, the patients of female physicians provide more biomedical information to them than to male physicians. And this may be related to the type of questions asked that stimulate the patient to disclose more.
Communications should be kept brief and simple. So 27 words total in print media allows for a quote, 9 seconds for TV and radio media allows for a soundbite, and you have 3 key messages. That's all the public can process during a high-stress situation. So this is a very good example about some of the background behaviors that happen during medical encounters. So you have, as I said, culture and doctor-patient relationship, personal characteristics of the patients and the doctors, and characteristics of the disease itself. Is it a life-threatening disease? Is it something that's chronic and can be managed? All of these are variables that affect communication. But also, what is the content of the communication? How advanced is the patient's illness, for example? We have to describe that. How is the relationship level with the doctor that's giving the information, and so forth. And then finally, the patient outcomes would be either satisfaction or compliance. So it actually has an impact on the outcome and not just that the patient feels better after leaving the encounter. The message that I'm trying to give is that communicating risk should not be avoided if it's operated properly. We can educate and inform the public and the patients, outlining the whole picture. and allow them to voice their concerns, and with better communication, this can be achieved.
So affected people obviously need reliable and accessible information very rapidly. And a significant difficulty is talking about effects and risks of exposure given the uncertainties and limits of knowledge. So we need to let people know the differences between science and judgment, and above all, to understand the individual's values and choices. We should try to have established places for dialogue. We should try to rapidly implement projects to address the problems that were identified. And this is an example of what was done before, since 2014, with a series of projects that we have been involved in to address some of the issues that were identified at the time. In addition, a common language should be used, and not too much medical jargon, for example. We also have to evaluate and disseminate any results we have, and develop practical radiological protection culture. And this allows the population to make choices and behave wisely. And one example of this is the current project that's looking at the returning population to low-dose areas, and how they can self-monitor in certain scenarios, etc. So when we think of risk communication, it is a cycle. So we go from risk communication systems to internal partner communication and coordination, then to public communication. But really important is engagement with the affected communities and communicating with them, and dynamic listening and rumor management, and then it feeds back into the risk communication systems.
So why is this important, and why do we need to improve communication? Well, ineffective communication results in negative consequences. We know that. We can easily communicate the technical facts, but and in some situations the safety information or individual risk, but in order to truly close the communication gap, we have to think differently. And this will allow us also to increase public trust in whatever official announcements come through. So there's an intersection of policy, of science, and of the capacity to do this.
Now, the risk communication systems that I was talking about takes into consideration several factors that we know, and one of them is that the audience's interest is taken to heart by the source, and that the source recommendations are grounded in factual information, and that the source of risk communication is more knowledgeable about the risk than the targeted population. Of course, that's not always the case. Other areas that we see, a change, for example, in terms of communication, is the media attitude change towards nuclear power in the wake of the Fukushima disaster. Not only in terms of the sentiment, but also in terms of framing. And it shows a long-lasting effect that does not appear to recover before the end of the period covered by this particular study that I show here. But not only the media, but also in terms of residents' risk perception, we see that exposure doses have not changed. The gap between the perception and exposure doses has not changed, even 7 years after the accident. And so for further recovery of Fukushima in the existing exposure situation, specialists in radiation health sciences must continue their efforts to communicate with the residents to narrow this gap between the perception and the actual exposure doses. So what about new technologies? Especially with COVID-19, we have issues with face-to-face visits. So the use of telemedicine has expanded significantly. And that's one area where we wonder whether communication can be effective. Is it inferior? And this particular source noted that the patient satisfaction of telemedicine versus in-person consultation seemed to be quite considerably similar. to in-person consultation. With the patient-centered communication, it was quite high. With the clinical competence, it was quite high. Interpersonal skills, the same. Convenience of care, as expected, of course, in-person was less convenient. But it shows us that we can achieve good communication even using telemedicine. So we can have a medical exam and a physician visit where a patient starts out as empowered and leaves disempowered. And that's not what we want to do. So we hope that we don't go down the spiral of lowered patient expectations, unvoiced frustration, and so forth. And in the end, it affects the quality and it declines. So there are certain things that we can do to improve the outcome. So like a welcoming ritual, being present, which is sometimes difficult when people are trying to type on the computer and so forth, but also choosing positive words. Nonverbal communication is extremely important, and many others, as you can see on this list. All of this enhances the patient experience and understanding. So it's complex in terms of communication, but it leads to worse results if we're not careful, and we need to be aware of all these factors. Finally, I want to very quickly go over some of the IAA activities in STS projects and the expertise within the IAA. So we have Department of Nuclear Applications, which has expertise in human health and radiation, but we have others also nuclear application that has IAA environmental experience, radiomics, and so forth. We have experience in soil and water and so forth. But also nuclear safety, where we have the Incident Emergency Center, we have waste management, and other groups within the house that also work with us. However, the cost and throughput differs when we're trying to measure. So for example, whether it's a high cost, low throughput government-based labs, or a single detector that could be also low throughput and low cost, but also high throughput opportunities, as you see on the right-hand side, which can be either low cost or high cost. So one example of the complexity is, as you can see here, for an average, this is a CRP or research project through the IAEA, for a dose that this snake got, for example, is very different because the behavior is different. So it adds another level of complexity to when we think about exposure. So in this case, it's on the tree, it's on the ground, or in the ground, and very different outcomes. And now just to mention some of the IAEA activities and reports that were published. I'll go through them very quickly. Here you see a few related to response, emergency preparedness, implementation of effective actions, many things that were learned and developed after Fukushima accident. At the time, there were many actions in terms of cross-checking monitors for radioactivity levels in water and air exposed to the accident, all the way through current, where the IAEA just confirmed the third batch of ALPS treated water in November and continues to engage in this area. You see some more examples of the IAEA response in terms of workshops and even an international conference on lessons learned 10 years after the Fukushima Daiichi accident. The STS approach is the interdisciplinary field, and that is very important. It's not only the scientists, but also society studies and technology evolution. We look at it within the social, political, and cultural contexts. So for example, if we have nuclear accidents, we noted in the past that the crisis of expertise in overdiagnosis of what the effects can be and the public health crisis can easily arise. When we want to communicate, we have to contextualize the information and be able to have a single source that's trusted and be able to weed out extraneous information.
And here we see examples of the STS projects all through the last 1 year extrabudgetary project that happened. And you can see that there were many technical meetings and others that happened during this time. The large network across continents can be seen here, and we hope to continue to increase the participation from different countries. On this slide, you can see the broad international network. 50% of participants were from Japan. However, as you can see, Europe, Asia, and other countries, other areas were participating as well. The diversity of professionals was not only in terms of what country they originated from, but also from the specialization. So you can see here the number of science and technology studies experts, the number of medical and health sciences experts, and the number of nuclear scientists as we move along, all of them working together within this project. If we look at the specialization from another aspect and divide it into humanities, natural sciences, and social sciences, you also see the diversity that is very clear in the participants. There were training workshops and technical meetings, and even when COVID-19 happened, we were able to continue virtually. There were poster sessions and young investigator sessions that supported young investigators from Hiroshima, FMU, and other universities, as well as the Phoenix program students. And here you can see some of the training sessions as well, some of them supported by QST. There were many outputs through this project, or these series of projects, and among these are handbooks, and some of them are jointly with social scientists, but also with nuclear safety colleagues and so forth. So it was truly a multi-dimensional approach. Here we see the non-IEA publications that were published and examples of presentations on the FMU site. So there was a plethora of useful tools and information that was shared. It's important to also note that curriculum development was an important part of the project. FMU instituted curriculum change based on STS methodology. Nagasaki University initiated a new master's program, and Hiroshima Phoenix Leader Program cooperated extensively in the STS projects. The changes that happen can be adopted to university and postgraduate education in other continents as well. And this has been a very important outcome related to this project. So now, to introduce you to the next project and the next phase, we have to present a little bit about Rays of Hope, which is a project by the IEA that hopes to leave no country behind, because right now, half of cancer patients need radiotherapy, and many of them do not have access to cancer around the globe, especially in radiotherapy. In most developed countries, access to radiotherapy is taken for granted, but the picture is very different in many developing countries. On this map, you can see the worldwide availability of radiotherapy machines according to need, and you can see that Africa and Southeast Asia face the largest shortages of radiotherapy technology, shown in red, orange, and brown. We estimate that 80% of Africa's 1.2 billion inhabitants have no access to radiotherapy and related cancer services. And this estimate is based on data from IARC and IAEA, and it assumes that 50% of patients with cancer will require radiotherapy, and that one radiotherapy machine can treat 500 cancer patients per year. If we look at the difference in equipment per million population between 2013 and 2021, where this was evaluated and reported, we see that most countries around the world had an increase in their equipment in low-middle income countries. There were very few that had decrease in equipment. However, this did not catch up with the increase in population and number of cancer cases, which went up significantly higher than the increase in the machines. Not only that, but there's a gap in human resources in low middle income countries. The total number of additional professionals needed would be almost 13,000 radiation oncologists, 6,500 medical physicists, 3,200 dosimetrists, and 20,000 radiation therapists. You can see that in Africa, we'd have to increase the number by 200%. So why are we touching upon Rays of Hope? Well, the reason is because the new project, the new STS project, will include Rays of Hope. And we have many opportunities for collaboration, not only through the STS projects, but through the practical arrangements with FMU, through the fact that we have a collaborating center agreement with QST and HiCare, and soon to be announced, hopefully, anchor centers with Japan. So to those who are not familiar with Rays of Hope, it consists of three main pillars. The first is to support access through technical assessments, buying equipment, and capacity building. As you saw, there's a need for training. The second pillar is sustainability through regional anchor centers, as I mentioned before. The third one is through research and development and innovation. The reason innovation is important is that so that we can train people better. We can use new technology like virtual reality that was developed at the IAA or other technology to help physicians become better physicians and train more efficiently. STS communication has an important role in this training. Generation of data through innovation and through the databases at the IAA will help us support the world in understanding the gap and the need for treatment and cancer management through radiotherapy and other nuclear applications. So, for example, on the right-hand side, you will see in blue that radiotherapy global innovation index was -1.4 and -1.3. Meaning that this is an alarming trend that cancer cases are outpacing the available technology. This cannot be done without these databases. In addition, the anchor centers that I mentioned before for sustainability are going to be a very important tool or for us to be able to train people from the region in STS through the education and training opportunities. And they will also support research, quality assurance, technology and equipment in the region, training on equipment in the region. Already the IAA has signed with 5 anchor centers, and you can see them on the map, but several others have applied, including anchor centers from Japan. So the anchor center is a knowledge hub for radiation oncology, radiology, nuclear medicine, and medical physics in the respective region, and will support capacity building through training of IAA fellows, hosting interregional, regional, or sub-regional training events, and provision of experts, including field expert missions, lectures and training courses pertaining to the region, and so forth. They will also support IAEA coordinated research projects in design, implementation, and follow-up. They will also provide training in clinical trials, design, and implementation. And they will support quality assurance in the region. They have a very important role and will be a vehicle for us to be able to train in STS and communication. A new project will be initiated shortly to continue the good work in Fukushima and address radiation risk in society and issues related to medical treatment of patients, including those through the lens of the Rays of Hope initiative. The scope of the current project is basically to train and apply radiation knowledge for medical personnel and improve communication skills related to radiation exposure, as well as to focus on the current conditions and what's going on the ground in the population, including with the regional stakeholders. So finally, in conclusion, we have successful risk communication, looks at, number one, the effects of risk perception, and we tailor the message according to the person's background. It's really important to understand how patients, as well as the local population, view this information, process the information. And one efficient way to improve communication between the concerned population, patients, and doctors is through education and, very importantly, interpersonal skills training. And that's one of the things that kind of training was done within the STS projects. Finally, I'd like to thank our colleagues in Fukushima Medical University, Hiroshima University, and the Phoenix Program, and Nagasaki University, as well as QST for supporting the training during the STS projects, and the government of Japan for supporting the STS projects. We look forward to working together and moving the STS projects forward and supporting the population and improving communication. Thank you very much for the invitation to speak today.
Thank you very much for the Thank you very much for the presentation. I think that the lecture by Dr. Abdel Wahab touched on starting from the basics and including the mechanism and principle of communication with patients and with the communities, and also expanding to the introduction of IA activities on emergency preparedness and responses, and also cooperation with Fukushima Medical University, including many of the projects and activities under the practical arrangement. And also Dr. Abdel Wahab introduced about the new project of the IAEA, which is Rays of Hope, to promote radiation medicine worldwide. Thank you very much for the presentation. Dr. Abdel Wahab, can you hear?
Yes, I can hear you. Can you hear me?
One question from myself. You presented this concept of communication with patient physicians or physician communities context, and what do you think is the application of what you talked to the population-wide survey or health monitoring, such as the Fukushima management survey that we are conducting?
Thank you very much for that question. And it's a very important question, because how are we connecting some of the work that was done in communication and STS techniques in what was presented today? I think the data that was presented is extremely important. But whatever data we have, or that's produced through various surveys or research or other types of fact-finding, basically, doesn't mean anything unless it is well understood. And communication has always been an issue for humanity in general, whether it's communication because of different cultures, languages, just experiences in life, and so forth. So our interpretation of what's being said can be very different. So in order to reach the goal of understanding what is happening and of supporting people in general, whether it's our patients, whether it's the general population, because a lot of times physicians are the link to the many groups in the general population. Any of these areas, it's really important to be able to have a very clear understanding. So if I'm a technical person, a scientific person, perhaps I will speak a certain way and use certain terms, and then you have a person who may be a teacher or a kindergarten teacher who has specific questions and wants to know the data, but might not, unless we all speak the same language and understand how to communicate better, the data, the hard work that's been done in collecting the information through the survey and other things will not reach its potential. So that's, I think everything is linked, and it's all related to how we communicate to each other to be able to have a clear idea of what the other is saying or presenting. Without that, you have misinterpretations, you have mistrust, you have a lot of things. And in your daily life, just in living as human beings on this earth, there are many examples that each person around the table today can give of times where they did not really understand something or somebody misunderstood them, and it's because we don't speak the same language. So STS is extremely important in being able to bring the different ways of thinking and concepts in a way that the information can be shared. I hope that's helpful.
Yeah, I think you stressed the importance of being on the same ground despite the difference in the background and knowledge level and expertise and so on. Thank you. I would like to move to some of the questions that we received from the audience. One of the questions touch on the study that you showed about the Kawauchi village, about the risk perception towards the 1 millisievert among the residents, that it has the risk perception is still high and has not changed during that period. How do you think these could be approached and remedied?
It's a good question, and it's a challenging question, and sharing data is important, but also being able to describe and communicate what, like the first one of the first slides that I gave is comparing things that we normally do every day, like flying, for example, or background radiation in certain areas. We had at one point through the STS projects, we had a couple of people from different areas in the world. One of them was a place in India that's known to have a high background radiation, and they were describing ways how they understood what this meant. So again, I can't emphasize, there's one thing about the measurements and the science and the numbers, and also very important to the self-measurements, because people would like to have control over this. So examples are the D-shuttle work that was done in Fukushima and others, that gives people the ability to measure and have control of what's happening. That's one thing. But then once we have all the numbers, the interpretation is even more important, the understanding of what it is. And I think there's more work that needs to be done in this area.
Thank you. There's another question regarding the community's trust to the experts, I believe. There are many instances in this question shown in the Zoom that, such as the incidents in Bikini Islands, and also the bombing of Hiroshima and Fukushima, which caused, in a way, the distrust towards experts. I believe that especially a person from the IAEA is considered to be an expert, and how do you deal with this distrust from the public?
So actually, I think that is not really my area of expertise. As you know, we're part of the medical group within the IAEA. But the one thing that I can say is it's very similar to physician-patient interactions. And the only way that could work is that if we're able to reach out to our patients and discuss the facts on the ground. And then the other thing is empowering patients to be able to make their own decisions and cull the data, get the information themselves, I think, and then make a decision. I mean, I think the time of having experts, give information and that's it that's centuries like this. Go back to at least 1 century. I think now people can actually measure for themselves, look for themselves, investigate. The average person who comes in for treatment will have gone through a lot of different websites and various things and so forth. With that freedom, of course, comes responsibility. And the responsibility is for the person who's online, Googling and finding information, to always look at the source of the information and make sure that it's a reputable source and so forth. But I think, again, it's a partnership. And I think it comes not just from experts talking to others. And these experts can be anything, as you know. So you can be an expert in one area, let's say a cardiologist, but you might not understand, let's say, radiotherapy. So expertise is a general term because there are so many subsets of experts and they don't necessarily understand. I know that Fukushima Medical University and others, as I said, have started increasing the number of hours for education on radiation through the programs that I had mentioned in the slides. And all of these have been very helpful, of course, in allowing medical students, the next generation, to have the skills to be able to communicate better, but also understand radiation. So it's interesting that even in the experts, in the medical experts, not everybody has the same access to specific training. And so I would say that it's important not to, lump people into silos, because experts or non-experts, it depends on what area, and it's a kind of broad spectrum. And not only that, but we have to remember that everybody, experts or not, are individuals and people. And with their own knowledge level in certain areas, with their own background. So I think the idea is a bit more complex than the silos that we like to think of, because it makes it easier to understand the world around us.
Well, thank you very much. We consider that the cooperation between Fukushima Prefecture residents and also Fukushima Medical University with the IAEA is extremely important and beneficial, especially for the activities in the future. And we hope to continue this with the agencies and with you from the Division of Human Health. Thank you very much again for your contribution to this symposium, and we would like to send the best regards to you and to the agencies. Thank you very much.
Thank you very much for the invitation to speak today, and thank you to all the people who are listening as well to spend time and learn more about this. Appreciate it and appreciate the collaboration. Have a good day.
Thank you. I think that will conclude the session for Keynote Lecture. Thank you very much.
Thank you.
So thank you, Dr. Tamaki and Dr. Abdul Wahab. Now back to Ms. Tsuchiya.
Now it is time to start the session 2. the bridges to the future for the people. Noret Sensei, Dr. Noret, please.
Now for session 2, Bridges to the Future for the People. This session will be chaired by Professor Tsubokura Masaharu and Associate Professor Mizuki Rei, whose biographies appear on pages 36 through 39. Beyond academic scholarship, both session chairs have extensive experience in person, on site, with people affected by the 2011 earthquake, tsunami, and nuclear crisis. Tsubokura Sensei, Mizuki Sensei, dozo.
Thank you very much. Session 2 is the bridges to the future and for the people. And Tsubokura and Rie Mizuki are leading this session. And I'd like to invite the presentation from 3 professors. And Uchiyama Tokio, or Professor Uchiyama Tokio's biography is on page 40. And also, he is the professor in 1958, after graduating the Junteido University. He is working as the pediatrics psychologist, and he's working on the mental health of the children. And right after the disaster, he's working with the children with a developmental disorder. He is now our vice president of this university. Thank you very much. And thank you very much for your kind introduction. And thank you very much for this occasion to speak in front of you. I would like to extend my gratitude to the faculty members of the Fukushima Medical University. I'd like to talk about the psychological effects on children in Fukushima and their care. And right after the disaster, there were some rumors, many rumors after the disaster, and someone was saying that it is likely to see more children with a developmental disorder. What we resumed that the infant health check early, just after the disaster. I wanted to share with you the data accumulated from that, and from the public health nurses from Hamadori. They mentioned the restlessness and the hyperactivity observed in children. And by collecting the data of the infant health check, I started to do the analysis. In March 2011, there was an earthquake, and after that, starting from that year, we started the health checkup. And actually, the 2009 was the starting year of the 1.5-year-old health checkup, and the 3.5 healthcare checkup started in 2011. And starting from 2018, we started the questionnaire survey with the elementary school. And also, we have conducted a survey with their parents and guardians. And this survey, after these surveys, we are providing the follow-up checkup. So therefore, we have combined the support in association with the survey result. And as you know, Hamadori, this area, is that the location of the Fukushima Daiichi nuclear power plant. And here, after the disaster, some people were needed to evacuate to other locations. And this is the survey of the 1.5-year-old health checkup. At this point of time, this is the time of the disaster. And this is the 1.5 years old health checkup. Before the disaster, it was 500 to 600 children got the checkup, and right after the disaster, the number of children went down, of course, and gradually it was coming back. There are many items in the health checkup, so I cannot introduce everything. But one distinctive one was, other than the mom, pop, do they speak a meaningful word? The people say yes are indicated in this graph. And also, point of something that knows about the picture book, and pointing the picture book, meaning the joint attention. So especially the social aspect of the children of the development of the social, and without this behavior, the autism spectrum risk can be questioned. So that can be the case without the pointing. And without the pointing, we don't have, regarding the pointing, we don't have the data from the before the disaster. So 10.6 is the highest. And this kind of move, what does it mean? It is difficult to determine that, because the total children who received the survey are very different. But and the pointing is, which is an indicator of the communication and the social aspect, and the 6.8% not able to do that, and compared to that, it is more than the double. But after that, it goes down, and again it goes up. So it is a very strange movement. And this is checked by the public health nurse. But as an indicator, the reliability may be low. So it is the difficult part to determine. And this time, this is a result of the responses by the parents and guardians about the children's behaviors, and if they have the impulsiveness or the hyperactivity and nighttime crying. Nighttime crying is increasing, and also the hyperactivity goes up again. And the impulsiveness in the year of disaster, it was very high, but it goes down gradually. And after the disaster, how children change are observed in some places, but what's common worldwide is that the children with the hyperactivity can go up, and that was observed in Fukushima and Hamadori, and the mental situation of the parents and the guardians. And there were questions regarding this. And right after the disaster, and the child care is fund, it goes down, but coming back. And the frustration is claimed, but it is going down. And this is a movement we see. The next, I'd like to share with you the result of a 3.5-year-old health checkup. Actually, there are some parts that the public health nurse fills in and parents fills in. And by public health nurses, and the children cannot say their names, went up all of a sudden, and with the peak of in 2013. And also, I was expecting the children with the impulsiveness, but it went up slightly, but went down. And also, the poor eye contact went up, but immediately goes down. So depending on the item, there are things that goes up immediately or takes a while to go up, but cannot say their name in full at the age of 3.5 years ago. Compared to the pre-disaster, there is a high percentage. What this means is that it's not easy to say what this means. And still, I'm searching if there is a correlation to anything else. And also, this is the response by the parents and guardians. And And in case of the parents, poor eye contact is very rare, but impulsiveness or restlessness goes up after the disaster. And looking at this, the children with the restlessness was high, and from the public health nurse, poor eye contact was high, but not by the parents. Probably parents did not pay attention whether the children had a high eye contact or not. However, the public health nurse are trained people, so they are checking the eye contact. And after the disaster, it went up, but coming back. And also that the impulsiveness and the restlessness and by guardian, parents, and the public nurse, the trend is about the same. Therefore, I believe it can be highly reliable data. And from the 2013, there's a time lag. And we are seeing gradual increase right after the re-exam. So the number of children is changing too. Now we are seeing the increasing number of children coming back, and also that the condition and the behaviors are changing, and also we have children moving in from other places too. So it is difficult to draw the conclusion immediately. And based on the result of the infant health checkups, and we were thinking the language development issues at the time of 1.5 years old. But the 3.5 years old health checkup, increase of children with the issues of restlessness, language development, and the acquiring the daily living skills. Actually, we haven't been able to do the full analysis yet. We are just getting the data so far. And why? We see the increasing number of children cannot say the full name or the children with the hyperactivity. And there are 500 items, and we are checking. We tried to see the correlations, but we haven't really finalized the result. And how long this incident or tendency continues. And while after the disaster, COVID started, so it makes the interpretation more difficult. And then the school age, what will happen to them? And in the future, when they grow up, what will happen? That hyperactivity will hyperactivity continue or not? And also, since we are in that clinical area, how we can act? What kind of advice should we give to the school teachers and parents? Something that we are considering. And let me briefly cover the questionnaire survey on the elementary school student. We conducted that from 2019 to 21. I talked about the 1.5-year-old and 3.5-year-old. Afterwards, they become the elementary school students and the junior high student. And we targeted, we focused on the second graders and fifth graders. And so what happened to that the following health checkup, it was difficult. We have a data. And regarding the elementary school children, it is the voluntary response. And so it was difficult to collect the high percentage. And if the data we were able to tie with the infant data, we had 139 cases for second graders and 100 cases with the fifth grader. And the second graders, which were surveyed, from 2010 to 12, they were born, and they experienced the earthquake from prenatal to 1 year, and the fifth graders, they experience a disaster from 1 to 4 years old. I was wondering whether we can find the differences of the impact depending on the year of the disaster. The method is a multiple logistic regression analysis. We adapted what we surveyed was gender and age and SDQ. And there's a questionnaire. And this is the global standard. And we have used that method. And also, the higher the score, the support needs is higher. And also, K6 was used to check the mental condition of the parents and guardians, whether they have a depression or anxiety, and also the health-related QOL, S of 8 and SF12 were used, and also the child rearing environment, and also the disaster situation, the evacuation situation at the time of disaster, and also the understanding level of the words and also condition of the parents were considered, and to find out the correlation and the results. The second graders, TDS difficulty. So whether the child has a high needs of the support, and if there's any concern about the behavior of the child, and with that child, what factors are related? At the time of a 3.5-year-old health checkup, we found that emotional issue, and also the sense of well-being by the parent was low, and they are still on evacuation, under evacuation. And these are the factors which could impact the behaviors of the second graders. And actually, what was distinctive was that impact found in the 3.5-year-old continues still till the second graders. And also the environment is impacting a lot. They are still on evacuation. And this is the fifth graders result, which was unexpected. At the time of 3.5-year-old checkup, and sometimes parents said they are not providing the enough support. And it was 7 years ago. And the parent felt the lack of support. That is impacting the behavior of the fifth graders. And also the lack of support from others or surroundings is also impacting the behavior of the fifth graders. And since we are the pediatric psychologist, we are paying attention to the words and behaviors. However, parents think the lack of support, and that has some impact on the behavior of the children. To summarize, at the time of disaster, and now compare the two different timings, SDQ impacting factors. And for the second graders, that the emotional issues at the time of 3.5-year-old health checkup, and lower sense of the well-being of a parent, and also long period of the evacuation life. And for fifth grader, at the time of 3.5-years-old health checkup, the mothers feel she lacks the support from the surroundings. So to summarize the result, the challenges in the future, and the parents and the children in high needs of the support at the time of elementary school, we need to intervene in an early stage because they have high needs of support. We should intervene with them earlier stage. And what kind of support should we provide to the mothers who needs the lack of support? And this is not clarified fully yet. So we'd like to work on this. And also in this region, and support and resources very scarce. So how we can provide the support, we should think about that and set up the system to provide the support. For that, we should be able to identify the parent and the child in needs of support. Because our resources limited, we have to able to identify them. And currently, we find it difficult to link between the infant health checkup data and the data from the school age. And in order to identify that, what type of parents and child needs what type of support is something that we need to clarify going forward, so that we can deliver the right support for the right recipient. Thank you very much for your kind attention. And thank you, Professor Uchiyama. And parent support is very important. That was a strong message, I remember. So we'd like to get the questions later on. Then we'd like to go on to the next presentation.
The second speaker is Mr. Yoshinori Katahira. After graduating from Chuo University in 1980, he joined Fukushima Prefectural government when the Great East Japan earthquake hit us. He was in cash control department. After he left the prefectural government, he joined Fukushima Collaboration Revitalization Center, being engaged in wide area evacuee support. Now he continued to support the wide area evacuees as the governor and of Fukushima Collaborative Revitalization Center. Over to you, Mr. Katahira. Good afternoon. Thank you for your kind introduction. My name is Katahima of Fukushima Collaborative Revitalization Center. I'd like to talk about how we support revitalization effort as well as wide area evacuees. First, what are the topics I will cover today? First, I'd like to talk about the Fukushima Collaborative Revitalization Center, and then I will talk about the support for wide area evacuees, then consultation program result. Item number 4, things we can tell from the changes of the consultation details. Self-introduction. I'd like to skip over it as the chair kindly has given introduction. So, Fukushima Collaborative Revitalization Center. Maybe this might be the first time you've heard about it. So before going into the content of the presentation, let me go over what it is. History of establishment. After the Great East Japan earthquake, a number of organizations, private organizations, started activities in the prefecture. But Most of them were focusing on individual needs support, and there was no intermediating mechanism. Of course, it's important to respond to individual needs, but also it is important to connect the dots or connect the people based on the needs to connect the people. We launched the organization Fukushima Collaborative Revitalization Center. We define our vision as the Fukushima vision, that is to for various groups to deepen their collaboration and to work to prevent and solve ongoing problems. What I have just touched on in diagram. On the left, so the challenges that was triggered by the nuclear power plant accident, and a number of organizations needed to get aligned. There are other challenges such as demographic challenges and isolation from the communities and society aging. And the issues are becoming more and more complex because of the effect of the disaster. We define it as the vision with the aim of establishing a mutual collaborative civil society Fukushima. There are three programs that we cover. One of them is coordination for disaster-affected people. Under this program, we help the people in Hamadori to reconstruct their livelihood. This is a picture of Futaba, where 8 municipalities got together last month. Second program is nurturing reconstruction support members, as well as community reactivating cooperation squad, community leaders. The picture shows how we conduct training courses and onboarding courses. Alongside with these programs, we also offer consultation and exchange program in support of wide area evacuees. Together with reconstruction agency that lead the program to support wide area evacuees. Under this program, we set up support centers all throughout Japan with other local organizations. And from the next slide, let me go into the details of support for wide area evacuees. But before doing so, let me once go over again the situation of the disaster and the nuclear power plant accident. On March 11th, 2011, the earthquake hit us with the epicenter of the coast of Sanrik with a magnitude of 9.0, the largest earthquake on the recorded history. giving a devastating impact in eastern Japan. As a result, TEPCO Fukushima first power plant lost external power. As a result, radioactive substance release risk went up. The government declared a state of nuclear emergency and issues instructions for evacuation in the nearby residents. On the following day, there was an evacuation order issued for the resident in a 20-kilometer radius. Some of the residents outside of the evacuation zone also felt anxiety and wanted to evacuate. The situation of the evacuation, the number of evacuees peaked in May in 2012 to 164,000. They evacuated to a variety of places all throughout Japan, and 62,000 people evacuated outside of the prefecture. The number of evacuees fell after that, but as of November 2023, 20,558 still stays in an evacuation place outside of the prefecture. In response to the situation, we collaborate with the prefectural organizations who dispatch the supporters all throughout Japan and set up support centers in 26 places so that the evacuees can rely on the support centers when they feel necessary. Information is also provided by these support centers. The consultation and exchange program, as we call it, are set up, as I mentioned, support centers in 26 places. Most of them are aligned with NPOs and other private organizations, taking care of the request from the evacuees. The program started in 2016, holding exchanges between evacuees. We also have some sub-centers in the centers. Most of the supporting organizations are private organizations such as NPOs, but some of them are concerned with specialist bodies such as Certified Public Psychologist Association or Social Workers Association. Now, let me go over the details of the requests that we received. This is the number of the requests we have received and its trend. Between 2016 and 2018, it trended around 1,800. But since the fiscal 2029, it's on a declining trend. In January 2020, the pandemic was broke out. As a result, we became unable to set up a face-to-face interaction event, and then the state of emergency declaration was made. then it was even harder to host such an event. As a result, up to fiscal 2022, it's on the declining trend. Request trend by age group. Age 40. 40 is the largest age group at first, which used to account for 30%, declined to 1/3 in the 6-year period. On the other hand, the 50s, which accounted for around 15% at the beginning, has more than doubled. Likewise, the 60s and the 70s and the 80s have increased, which means that the older people now accounts for higher percentages. Some of the long-term service users has turned 70s from the 60s or the 80s from the 70s. Then let's look at request categories by consultation contents. At first, the most popular consultation content was housing, and the likelihood accounted for only 10%, but this livelihood content is on a constant increase and has more than tripled to 34% in 2022. It seems that the changes in the life stage and aging with the prolongation of the evacuation has highlighted the livelihood issues. Then from here, allow me to pick chronologically up major concerns expressed by evacuees. The first year, in 2016, a lot of inquiries and requests were made regarding housings. In 2017, housing-related concerns were expressed by evacuees from the designated areas. Also, this was the time when a rent-free period was lifted. Relevant requests were often made. In 2018, a number of requests was made by evacuees who seemed to have mental health issues. In 2019, since the temporary housing program ended, request related to relocation request was often made. And for the last couple of years, quite often the requests were from the older people who are in difficulty because of the aging. Things we can tell from the changes of the consultation contents. As we have chronologically looked at, the changes are somewhat made by the end of the support measures and the changes of the lifestyles of evacuees. And with the passage of time, the challenges faced by evacuees shifted from evacuation-specific topics to livelihood-related topics. But there's one constant topic that is isolation from the community. And all of them are combined, making the challenge more complex for the evacuees. There are a number of reasons that isolate evacuees from the local community. After the disaster, it might be hard for them to reconnect to community once the ties are lost. If they are isolated, their difficulty might go unnoticed, and it's hard for them to speak up, even in the difficulty. And the elderly people and those with mental health issues might have difficulty in accessing the right information and to reconstruct their livelihood. Therefore, it is unrealistic to expect that all the evacuees can access a necessary government service without difficulty. Also, since the issues faced by the evacuees is quite complex, it is hard to be addressed by a single agency or organization's effort. We might to combine multiple agencies in addressing the challenges. Multi-layered support system development project initiated by the government. The project was launched as the new project reflecting revisions of the Social Welfare Act. So summary. Latent problems of a local community may surface because of the loss of support from community functions by the collapse of the communities due to the earthquake. That may cause various difficulties in resolving problems at the place of evacuation. The framework for various types of collaboration on a regular basis is important. As to creating that framework, multi-layered support system development project and the disaster case management movement are helpful. We have been involved in the support of wide area evacuations caused by the Great East Japan earthquake and the nuclear disaster. We believe that we must take lessons from this experience and disseminate what we have learned for the disaster preparedness. We anticipate that another disaster might happen, for example, the Greater Metropolitan Area disaster with the direct epicenter Venice. So it's important to prepare for that at the peacetime. Thank you for the opportunity. This is the end of my presentation. Thank you, Mr. Katahira. There are a number of evacuees spending their time outside of the prefecture still. The changes of their needs and status, and we are reminded of the importance of continued support for them. Thank you.
Okay, let's move to the third presentation from Dr. Tamaki Tomoaki. So the presentation title is Risk Communication and Support Activities of Radiation Medical Science Center for the Fukushima Health Management Survey of the affected municipalities. And he is a professor in Shared Department of Health Risk Communication, FMU, and also director of Office of Risk Communication at Radiation Medical Science Center for FHMS too. My name is Tamaki Tomoaki. And today I will talk about the risk communication and support activities of Radiation Medical Science Center for the Fukushima Health Management Survey for the affected municipalities. So the objective of Fukushima Health Management Survey, or FHMS, is that the external dose evaluation, which was caused by the Fukushima Daiichi nuclear power plant. At the same time, we want to ascertain the health status of our people in Fukushima Prefecture, so that they can receive treatment as soon as possible. At the same time, we want to promote the better health of the people in the Fukushima Prefecture for the future. And we have two pillars in this FHMS. One is a survey and also support. Through survey, we want to have a precise and accurate understanding on the status of the people in the Fukushima Prefecture, and also that we want to understand the needs of the residents in Fukushima, and at the same time, we want to offer strong support so that they can maintain their good health or the health status. In the first part of my presentation, I will focus. Earlier today, there was a presentation focusing on the result of FHMS as well as the support. But in my presentation, I will focus on the activities in order to offer our supports going forward. So this is about the basic survey. This is going to be a repetition, but in this survey, we focused on, we covered a 4-month period after the accident, and based on the behavior record of the residents, we have estimated external radiation dose. So important point is for all to the respondents, and we notified the result of our estimate, dose estimate one by one, giving accurate information on that dose to each individual, so that that can be used for them to manage their health going forward. Next is about the comprehensive health check, or CHC. Due to the nuclear power plant accident, many people have to evacuate, which gave a major change to their living, and many of them had anxieties concerning their health. That's why we have conducted CHC. Through this CHT activities, we want to understand that health status of the residents, so that they can receive medical care support as soon as possible. And other people who took CHC, the result of the health check was notified person by person. And also the summary of the result of CHC, and also a leaflet to promote better further health, and including those pamphlets, we have distributed this information to the wide range of the residents. Number 3, all the people who received the CHC, and we put together the report based on the report we got from each municipality. So we have a liaison meeting among 13 municipalities which were affected by that accident. Then we are organizing that meeting on a regular basis. At the same time, we conduct health seminar, which is and we conduct like health seminars by doctors, and also that like individual consultation service, which is provided by experts like public health nurse and others. From 2016 to 2022, such seminar was organized 177 times in total. So support for TUE, or thyroid ultrasonic examinations. I want to give you the overview. Concerning the primary examination, we have established a booth so that physicians were able to explain the preliminary result of the examination using some images. in an easy to understand way. In the confirmatory examination, nurses, mental health social workers, and clinical psychologists, and also medical social workers, they worked as a team to support the person, the participants, as well as their family members from psychological and also social perspectives concerning their thyroid gland. In our generation, or adolescent and young adult generation, we are offering now peer support for the people who experienced thyroid gland cancer. And the participants of the examinations and also their parents or guardians, we send thyroid newsletters twice a year, and which includes latest information as well as Q&A, the frequently asked questions. So through these activities, we are offering like the physical and also mental support to that the survey participants, or the examination participants and their support in the family members. Next, about the activities just focusing on TUE, and which was presented in session 1 too. The first activity is that if any school requests, we can send expert staff members to the location of the school so that they can give a lecture, so-called on-location lectures, to give easy to understand explanations over TUE. So we can offer accurate and easy to understand information. We have different literatures or the materials for elementary school children and others. And the second support is on-location information sessions, which are offered to this is upon request. Lectures on TUE, medical information on thyroid cancer are provided to the family lectures. Municipality teachers, municipality workers, and local residents, in order to so that people can deepen their understanding on the thyroid cancer. Mental Health and Lifestyle Survey, or MHLS. This was presented in session 1 too. The support is very important in this survey. The experience of the earthquake and also that nuclear power plant accident, the residents have anxiety and stress. So we need to understand their status, health status accurately, and also their lifestyle too, so that we can offer appropriate care to each individual. So in MHLS, just like other surveys, we notify the result of the survey to each individual, including simple advice which can be useful for their healthcare, and also the individual that we send a letter, including the result. And based on support criteria, we offer telephone support as well. Supporters check the physical and the mental condition of the person, and they try to understand the needs of the person so that they can offer specialized advices as needed. And we are making a call to about 3,000 people to offer support. The third one is sending out the pamphlets. We are sending out health information and also the contact information of our healthcare institutions, and also where to consult to. This is so-called as support booklet. We can offer beneficial information at the same time. We are providing information so that they can receive additional support. The fourth support is that We gather all the survey results from municipalities, and when we have the liaison meeting among 13 municipalities, we provide specialized or the specialized advices or the advice from the experts. If anyone needs to receive a support, then and we collaborate with local health and support organizations as well as healthcare organizations so that people can receive support. Next is about support activities for pregnancy and birth survey. So the main purpose is to provide support to people with pregnancy and giving birth. Dedicated midwives and also public health nurses make a phone call or send an email to offer consultation support. And at the same time, a so-called support booklet for mental and also physical conditions of mothers and also babies. And we send out this leaflet. At the same time, we collaborate with like a clinic, with the clinics to offer support. And this survey has been completed already. But the learning from this survey can be used for pregnant women in general. And this is about the Yorozu health consultation at the municipalities events. So residents have anxieties and stress, and then we want to offer appropriate support to them. That was to support their physical and the mental conditions, and it was organized at municipalities, CHC, and also the events to give the medical check results. So from 2012 to 2017, it was organized 723 times, and until 2016, and from 2017, it was taken over by Fukushima Medical Association. Now, lastly, next I want to talk about liaison meetings with 13 municipalities. FHMS, this is entrusted by Fukushima Prefecture. But collaboration with municipalities and also in providing support is the most important support. So at our center, we organize liaison meetings with 13 municipalities so that we can exchange information about the mental and physical status of the residents in Fukushima Prefecture, and we are trying to use that to offer stronger support. And we exchange information with 13 municipalities, as you see on this slide. And the public health nurses and health and welfare staff members of the municipalities attend this. By strengthening such a collaboration, we want to be able to offer appropriate and suitable support. In this meeting, person in charge from our center is engaged. The health communication, the Office of Risk Communication, Office of Health Communication, Office of Public Communication, International Cooperation, and those members in those organizations and relevant staff members of each survey take place in this meeting. The contents of this meeting is that the report which is given to the Oversight Committee, including the progress report on the survey and also the municipality-specific report of each survey. Such information is shared among the municipalities to exchange opinions. The current status and the needs of health promotion activities, we have a free discussion over those topics. At the same time, we introduce the information about the events, such as international symposium like today. So this is a photo from the liaison meeting which took place in Minamisoma City, and we tried to create environment so that the people can exchange their views freely. About the contents of this liaison meeting, we mainly focus on the articles covered in newspaper. At the same time, using 30 minutes towards the end of the session, we try to have a free discussion time. In 2021, 17 times in total, 2022, 20 times. This year, 22 in total so far. We have organized those sessions. And altogether, from 2013 to 2022, we have conducted this meeting 342 times in total. As a part of the support we offer in this liaison meeting, I want to introduce some of the support we have been providing on a continuous basis. And on the left, in Kawabuchi village, we dispatch public health nurse so that they can consult with the people. On the right, that's the photo from so-called dumbbell exercise in order to promote health. And there was a request to send our physical therapist. And staff members actually liked that, and they also participated in this exercise too. And this chart summarizes what I just explained to you. We, as Radiation Medical Science Center for FHMS, our center, and also 13 municipalities in the liaison meeting connect those two. Based on, we offer information and also result of FHMS, and also we get requests, comments, and questions from each municipality. This is managed by risk communication committee for evaluation of risk communication, including internal and also external members, and we collaborate with the university. And if it's needed, we try to offer additional support as well. So in the end, through this liaison meeting, in the opinions and requests from 13 municipalities are factored into FHMS as well. So to summarize, the support to residents through FHMS is the most important activity, especially collaboration with those 13 municipalities are very important. So we want to offer information. And going forward, we will try our best so that we can conduct survey and those activities which are in line with the requests and also the current status of those municipalities. Thank you very much for your attention. Dr. Tamaki, thank you very much. He talked about the liaison meeting with 13 municipalities and other support activities. It was a comprehensive presentation. And if you have a question, would you please, ask questions in the Q&A session in the end. Now we are going to have a short break. If you have any question to session 2, no, we cannot. We cannot take more questions anymore for session 2. If you have questions, would you please write down in the questionnaire and put it into the box? And we are going to start the next session from 4:25. Thank you.
So since it is time, I would like to start the discussion of the session 2. And Dr. Tsubokura and Dr. Mizuki, please. Thank you, and thank you for waiting. And we'd like to have a discussion session for session 2. This session is about what to do in the future and what type of support do we need to have for the future. That should be the focus on this discussion. We have received a lot of questions, so I'd like to ask the question one by one to the professors and Professor Chiyama. And the fact, this is rather a confirmation of what you presented. 1.5-year-old health checkup, and this there was no data for the worst and also the impulsiveness. That's true. We didn't find that. So it is not the usual survey, right? It is different, and the type of survey is different from region to region. And it is the municipalities who decide the items of the questionnaire. And they just happened as a coincidence. We had the same questionnaire item. So at the time of a disaster, you already had the survey planned on the specific item. Yes. And in that question, compared before the disaster, there was an increase of what it's not described. Yes, is that true? But as I said, depending on the item, there was an increase and went up and down. And for instance, the late in learning was, and depends on the item. So it depends on the question and it depends on the characteristics. And some went back immediately. And the next question to Katahira-san. And the first question to Mr. Katahira. The livelihood difficulty, you said that the increase in number of questions are related to the lifestyle. And what are the typical solutions that you suggest? Thank you very much. Depending on the individual consultation question, of course, the cases vary, but as necessary, and we we refer to that the social welfare liaison office and or local food bank usage. And depending on the case, the contact of the local government or the caseworker for the medical institutions. So we are bridging the people with such professionals. So the social resources in the area is used so that the person can reach the support they can receive. Yes, that is the ideal situation that we are seeking to do. And sorry to interrupt, sorry. And the evacuees, how do they know your activities and start to contact you? There is no formal analysis done, but generally, not only the consultations, and there are some exchange forum. So through such event, the people know there is a point of contact. Yes, thank you very much. And sorry, next, Dr. Tamaki. But you talked about the liaison meeting, and for instance, you have a lot of occasion to talk to the public health nurse. And what are the atmosphere and questions do you get? And as far as you can tell us, could you share what type of people and atmosphere you have? And as I said in the presentation, 13 municipalities liaison office, liaison meeting, rather than the ordinary citizens, they are the staff members of the municipalities and the public health nurse from the municipalities. In the question I received, for instance, radioactive substance and the food-related question, and there was a question if I received such questions. But the people we are talking to are talking about the insurance or the food. So it is true that this question is not so relevant to me, but I'm radiology oncologist to begin with, and I see myself as a specialist, and I'm hoping to provide the professional information from my side too. And when I ask the question, how is it? And then the public health nurse, as their own feeling to the anxiety towards the radiation is going down. So it seems it is getting less related to the question of the radioactive substances. However, since I'm a specialist in radiation, I would like to, and I see the need of providing the continuous information in my area of expertise. And as much as possible, we would like to establish the two-way communication. So, and the people, the staff members of the municipalities, a lot of them do not know the detail about what we are doing. So what's presented, I would like to summarize the contents so that accurately I can communicate with them. So other information we receive, and 13 municipalities have a different situation, so it's hard to generalize that, but they have a hard time when they pursue their activities. And the recent case is that the COVID response made that the public health nurse so busy about the vaccination. So by having the vaccination, they have more contact with the residents, and using that opportunity, the public health nurse are communicating the relevant information. And I heard, and what was impressive was the returning situation from evacuation varies too. Originally, what to do with the people who return and what can be done with the evacuees so that they can come home. And it is very difficult to have access, and the nurses are saying that it is difficult to have access to the people who are evacuating. So I see I have a lot of findings that I can only gain when I go to the field. So I would like to provide the information to support them. And I would like to make the liaison a meeting so that they will be effective to promote the support. Thank you very much. And I have just heard that the additional information. I believe there are municipalities have different phases, and the lifting of that evacuation order happened long time ago with some municipalities, and some municipalities have only recently lifted the order. So depending on such phases, we need to really tailor-make the support. And going back to Dr. Uchiyama, And in your presentation, you said that the impulsiveness and the word situation went down and improved again. And you mentioned, and what was surprising to me is the low perception of the well-being of the parent. That is impacting strongly. And that's convincing if you say so, but do you know the cause of that and what can be done for this? Thank you very much. And the overall sense of well-being is captured different from FSA. So as an overall question, how do you feel your well-being and great and so and bad? And they are supposed to respond that way, and that is used as one indicator. And also, there are other items in that checkups. For instance, they cannot be energized or they can be energized. And we are using such items to do the analysis. But lack of support is often mentioned. And that is the subjective view. And also the long-term of evacuation life. And that are linked with other factors. As I mentioned, the state of the children, for instance, impulsiveness, I couldn't find a strong linkage between that behavior and the mother's mood. And in other city, they have captured a good linkage. Then there, the developmental indicator of the child and the support needs are well linked. And the health state of the parents or the mothers are linked with the children's condition too. So in this city, the subjective view of the mother is linked strongly with the overall perception of the well-being. So I shouldn't say based on the estimate, but the Amadori, the social structure has changed and the region itself has been changed. And the bad condition of the parents are strongly linked with the state of the children, in my view.
Thank you for your answer. Let me continue my layman question. I can vaguely image what are the typical questions by the guardians or the parents. We sent clinical psychologist to the infant health checkup right after the disaster. In the year 1 and the year 2, so many concerns were expressed regarding the risks of the radioactivity. So we considered it's important to deliver accurate information. But in year 3 and year 4, uneasiness of the children and some expressed concerns related to the changes of the family members. For example, they become there are fewer number of the family members, and the father left Fukushima to get another job outside of the prefecture. Then we were required to give necessary advice. Also, social structural change that they were no longer able to go to the kindergarten that they attended before the disaster. And that created some uneasiness among children. And as a result, there was a higher number of the violence toward the children in Hamadori area compared to the level before the disaster. Let me come back to this question regarding how the trend has changed in the year 5 and year 10. And let me ask another question to Mr. Katahira. You provide support to all the residents throughout Japan. When you contact with over wide area evacuees, you might feel special challenges. Any conspicuous challenges are what? Thank you for that question. Now we are making the 13th year following the disaster. During that period, there has been a lot of other disasters such as typhoon and also a disaster in Noto area recently. So the word evacuation should not only be used to evacuation associated with the Fukushima nuclear power plant disaster. And then it's hard for the general public to understand why they are in that area. So lack of understanding. And how would that impact on the evacuees? Could you give me specific examples? So instructions for evacuation was issued by the government following the nuclear power plant disasters, and some voluntarily evacuated, and some still registered as a resident in the evacuation zone area. There is some systematic support system. However, that is not always available 100%. Maybe it's needed to get them understood, but still it is hard. Allow me to ask you this layman's question. So if you could elaborate, when an evacuee asks for support in the municipality that they are currently in, they cannot expect smooth support. Is that what you mean? Right. They quite often ask why they do not register as a resident to that municipality when they ask for support in another municipality. When they commute and when they go to a school, they have to make other people around them understand that they are in that community for evacuation, not just a simple relocation or a change of the jobs. So they cannot ask the support and cannot get the support immediately in another municipality. And I quite often hear that case. How do you address that challenge? We typically co-visit. We also talk with the officer in that municipality. There are a number of ways to address that. You've got a widespread network of support which enables you to give face-to-face support all throughout Japan. That might be quite a large encouragement for them. Okay, let me continue the question. My question then is, what motivates you when you are engaged with support of wide area evacuees? What motivates you? Contrary to what I have just mentioned, when another disaster hit us, my experience in the Fukushima disaster is quite positively evaluated, and we will be seen as a very trustworthy contact. A number of local government have asked us for support. So you are getting more widely recognized among the centers who offer support to the evacuees, not only among evacuees. Okay, got it. Thank you. Now, let me direct another question to Dr. Tamaki, a somewhat a different question. Let me read it aloud. I have been living in Fukushima City. Right after the disaster, I have been worried about the high radiation dose, and some of the friends asked me to evacuate to their place, to join their places. But I did on my own study and got an information that it might be actually worse for my health to overly concerned about the radiation hazard. But still, some of my friends are evacuated to a long-distance place, and which makes me think that the stigma associated with living in the Fukushima remains. And what kind of advice can I get from you? I am a radiation oncologist, so my specialty is to use radiation to cure cancer. Radiation is quite a tough thing to find a good use of it. In Japan, based on the result, based on our history, which include how Fukushima nuclear power plant accident have developed, it's in some way understandable that the people still have that perception. In the presentations today, some talked about risk perception of hereditary risks. Right after disaster, 60% said there would be a risk, but that has been improved and the percentage has reduced to 30%. But when we look at individuals, there is a gap between those stayed in Fukushima and those evacuated outside of Fukushima. The risk perception is, of course, higher outside of the prefecture, and that is well reflected in the percentage figures. Now, people outside of Fukushima considers that hereditary risks are higher. So it's actually hard to address this perception gap. So what can we do to rectify the bias? Based on my own experience, let me talk about that. And I am a clinical radiology oncologist, and then where I have to explain both of the benefit and the risks of using radiology. And people will then understand that the fear and the risks of having a cancer is a lot higher than the fear or risks of having radiation therapy. And people start saying that I trust you, doctor. And sometimes they say that I do not understand the science, but I trust you. Do whatever you want. Then, how to react to radiology and how to react to radioactivity, how to face the fear that or distrust. The attitude determines the action, and I fear radioactivity. When people say that, you have to think about the background of the person saying that, and that's it, I believe, most important. And for voluntary evacuees, says that Fukushima is a dangerous place. It's hard for you to get them convinced that actually Fukushima is not a dangerous place to live in. Rather, you should address the source of their fear or try to get them trust you. And for me, that is more important. And if they say that they are concerned about radioactivity or the radiation, then you maybe have to drill down their fear until you two can discuss together as to what action could be taken to alleviate the fear. And that's where what the risk communication is all about. It's important to talk about radiation and radioactivity, but there is something else that is totally unrelated to radioactivity, or fear, or anxiety, or peace of mind, and your communication strategy needed to be positioned somewhere between the two.
As this person said, we need to try to understand the needs. We need to have a close communication. After we establish such a relationship, then maybe, oh yes, we talked about that radiology issue before. As I'm like in past memory, I think this is relevant to FHMS too. FHMS is focusing on how to maintain the health of people, the residents of Fukushima Prefecture, and we want to try our best to attain that objective. And in the end, so there is not, if people can feel like there is no like major impact from the radiation, maybe that's how they can perceive that way. Eventually, sorry, it was a very, very difficult question for you to answer. My apologies for that, but everyone who is engaged in the radiations, and we have, encountered this obstacles so many times, and we have not been able to overcome this challenge yet. The scientific facts are important, but can we trust that we can only communicate the facts if we have a trusting relationship. And of course, we are accumulating all the facts through FHMS. At the same time, we need to try to gain the trust. That's very important as well. We have other questions too, so may I ask Chairman-san? Sorry, Dr. Okuchiyama. So you shared a different a wide range of data, including like temper and others. Impulsiveness and K6 has been coming down. However, it's higher than the average in general. But we have seen some improvement in some of the data. And compared to that, the data you have, what is needed? Not about the 50 year, but it has been 13 years, and looking at like farther down the line in the future, what will be needed? So would you please elaborate on that from that perspective? The data I showed you today, Hamadori area, and it's now Hamadori covers a big wide range of the area, and that is a regional difference. And of course, within Fukushima Prefecture, Hamadori and other areas are different. So we have to, be able to provide a suitable support in each area. Hamadori, we have new people like moving to the area. There are like 3 different groups of people, like people having living in that area, and also people came to live in the area as a new residents, and there are schools too. It's like towns and also villages. We need to check the situation in each area, and we need to think about what's needed to that particular town. For example, Hamadori is that how we call this area, but within Hamadori area, the situation differs by the places. So K6, the result was as SD. So we need to focus on each individual to offer different types of support. So I think that's like we need to focus on like more small, more granular areas. I think that's a key word. And what should be the optimal size for the area? Maybe it could change time to as time goes by. Macro or micro, there are different units to describe that. But family by family, that can be 1 unit, or by town or by village, that can be another level. And people have a different sense of value in different towns and villages. We need to have a close communication with people in that particular area. Thank you very much. And Mr. Katahira. Next question. Let me read it out. COVID-19, because of that spread of the infection, I understand that people's needs have been changed. So post-COVID, what is the direction of new way? What's the new needs? What kind of support you need to offer post-COVID? So this is not in the scope of the project we have entrusted by the prefecture, but this is our view towards the future. Earlier, I did not enough time to cover this. In order to solve the issues that people have who came for consultation, and we need to link them to the regional resources. Connecting them each time, case by case, then we won't be able to resolve those challenges. So even if in the normal state or normal situation, we need to think about what kind of measures we should implement. As I said earlier, briefly, that it could be a big disaster in the future too, and we can think about different disasters too. So region by region, all the organizations and parties have to be collaborate with each other to achieve it. No, and it's difficult to have such a collaboration without a purpose. We have to have a purpose in order to collaborate with each other. So like disaster control, like disaster case management can be done. And other programs, we need to leverage those so that we can establish an environment where we can have face-to-face communication. Thank you. One more question to you. So wide-range evacuees on providing support to those people from the 5th year to the 10th year that needed support during that period, and also further down the line, like from 10 years from today until 15 years from today. What kind of support will be necessary? Is there any difference in the types of support to be required? As time goes by, then challenges change. When 10 years passes by, then 40 years old person will turn into 50 years, and 60 to 70. So then 20 years from today, that means that people who did not receive nursing care, but they have to receive nursing care support, and whether their parents have such a challenge. So chronological, the time can change the challenges for people. Is it a short-term support or a long-term support? They are different in a point of discussion, but region by region, we need to establish such a structure. I think that's important. Thank you. So we need to keep changing that too. I want to ask the same question to 3 people, starting with Dr. Tamaki. For this session, what kind of support should be provided, and also the as original purpose of FHMS, we want to keep supporting them in coming 5 years to 10 years. What will be needed, and I think this is a similar topic as Mr. Katahira explained, but would you please share your thought? Concerning FHMS, based on the result of the survey, we need to keep striving in order to overcome such health-related challenges. And from my position, radiology and also the image of Fukushima Prefecture, I think people will start forgetting. And as the people forget about it, then maybe negative image can fade away too. But if people stop talking about Fukushima, then maybe negative image will be fixed in their mind. For example, the effect from the radiation overdoses. We need to keep providing information. The data we found out through FHMS, we need to keep communicating that information, especially the impact on children. There was no impact on children. That was a finding from the pregnancy and birth survey. Thank you. Mr. Katahira, as Dr. Tamaki said, This kind of like wide area evacuees, we still have that challenge, and we need to keep talking about it. Last year too, there was a company there was a seminar focusing on social challenges, social issues, and I attended that seminar, and people did not know that there still are so many wide area evacuees today. This is the issue we have, and what is the current status? We need to keep communicating that message. Dr. Uchiyama, please. Yes, I think I will share the same views. One point is like the effects by the radiation. People have negative perceptions, and after we repeat clinical studies, then we can finally eliminate such a negative perception. So accurate information should be communicated on an ongoing basis, and also empower the local people, like local supporters. They can gain skill in order to support children and also their parents. I think that's very important. That the program that can be used by the local residents, if we need to develop such a program and offer that the program and local people can keep revising the program. And also the guilt, there are many people who are feeling the guilt among the affected people. And then the supporters, they're feeling so stressful, and we need to give them an opportunity so that they can consult with other supporters. Sorry, I'm not a good timekeeper. We are behind the schedule. My apologies, but thank you very much for exchanging different views. And I'm now living in Fukushima. The meal, fruits and vegetables is so delicious, and I cannot lose my weight still. But at the same time, that nuclear power plant accident, we need to keep communicating and providing information on an ongoing basis. But thank you very much for your time. This is the end of the session.
So this concludes session 2. We will proceed directly to our closing session with comments from Professor Hazama Akihiro. Even as a university vice president directing the Fukushima Global Medical Sciences Center, Professor Hazama chairs a busy and productive Department of Cellular and Integrative Physiology and directs a nonprofit organization called the POM-K Project to popularize medical knowledge among school children. So, Professor Hazama, as soon as the podium is ready.
Thank you very much for your kind introduction. I am Dr. Hazama of Fukushima Medical University. I would like to say a few words to close this symposium. In 2024, and to open the Fukushima Medical University International Symposium on Fukushima Health Management Survey, we are very grateful to get your support from many of you, and we are able to successfully conclude this symposium. And thank you very much once again. We feel honored to have a number of experts from Japan and abroad speaking at this symposium, and they share their valuable insight from the field of their expertise. And the discussion based on the questions from the participants was a meaningful opportunity to deepen our understanding of the Fukushima Health Management Survey and the current situation of Fukushima. I would like to take this moment to reflect on the contents of today's lectures and discussion. Session 1, our faculty gave presentations on the findings gained from the basic survey, understand the external exposure doses, and the detailed survey to understand the health conditions. Keynote lecture by Dr. May Abdel Wahab, Director of a Division of Human Health Department of Nuclear Science and Application of IAEA, presented the recognition process of the radiation effects method of radiation risk assessment and the initiative to improve the risk communication between experts and the general public. In session 2, from the viewpoint of capitalizing on the gained knowledge, ongoing research and activities and their future prospects were presented and discussed to keep and promote the health of the people in Fukushima and to be prepared for the emergencies in the future. And Dr. Tokyo Uchiyama Tokyo of Fukushima College introduced the initiative to study the necessary support needs based on the group questionnaire survey with the parents of the children who experienced the disaster at their infant age because of the issues found in their language development. And Director and the Secretary General of Fukushima Collaborative Revitalization Center presented the support activities and consultation of and exchange program for evacuees living outside of Fukushima. Mr. Katahira shared the importance of the supporting the evacuees as a local residents of the new communication based on the changing consultation topics. It was a great pleasure to share thought-provoking discussions from a wide range of perspectives and to gain the many meaningful insights. Our university will continue to contribute to reconstruction and revitalization of Fukushima by strengthening our ties with the world and will also continue to stay close to every one of the people of Fukushima to support them, support their health through Fukushima Health Management Survey. In closing, I would like to express my sincere gratitude to all of you who participated and cooperated in this symposium and ask for your continuous understanding and cooperation to our university. Thank you very much.
Thank you, Vice President Asama. This concludes our 2024 International Symposium. Doji Tsuyaku-san, thank you for your hard work all day. I'm adding 3 new sentences. Do your best. Several times per year, in between these annual international symposiums, members of the Fukushima Health Management Survey present their findings to what is called Kento Iinkai, the Prefectural Oversight Committee. Each of these meetings is followed by a press conference. So, Kento Iinkai days are when questions from independent subject matter experts and media professionals have the highest priority. Back to March 2nd for the people. To all who have participated today in Tokyo, in Fukushima, and online from all around the world, thank you for your time and for your continued thoughts about how to share lessons of Fukushima with Japan and the world. Good evening.
With that, 2024 Fukushima Medical University International Symposium on the Fukushima Health Management Survey is closed. I would like to ask once again to fill in the questionnaire when you leave. And if you're in Tokyo venue or Fukushima venue, please fill in the paper form and put your response into the box. Or please read this QR code to give us a response. And if you leave the Zoom room, and there is guidance, and following the guidance, please give us the response in the questionnaire sheet. We will also send the questionnaire sheet via email, and we are hoping to get your inputs. And this symposium is scheduled to be broadcasted as an on-demand broadcasting. And thank you very much for your participation today.